3, 2, 1, live.
Thank you. A warm welcome and pleasant evening to all of you. Let's begin with this cesarean workshop, which is a useful addition to the series of workshops being organized under the able leadership of key organizer, Dr. Sadhana Gupta ma'am. I welcome Dr. Sadhana Gupta, who is the key organizer and the most able, dedicated, hardworking, and great academician, and is the FOGSI presidential candidate with commitment and conviction. Over to you, ma'am.
Thank you, Ritu. And as a key organizer of this series E-Classic for Clinician, which we are holding since around 2 years on a diverse topic and on the focus topic, I welcome each and everyone. My special gratitude to Uttarakhand State Chapter President Dr. Meenu Vaishya and Dr. Archana Singh, Secretary Uttarakhand Chapter, who have coordinated and put all the great effort to bringing us together on this day. So we are there today for all going into the intricacy and the complexities of the cesarean section. My special gratitude to Dehradun, Haridwar, Haldwani, Kashipur, Roorkee and Rudrapur Society, Dr. Manisha Singh, Dr. Anshu Kakkar from Dehradun, Dr. Jayashree Tiwari, Dr. Anushri Rawal from Haridwar, Dr. Sangeeta Singhal, Dr. Sujata Pradhan from Haridwar, from Kashipur, Dr. Archana Chauhan, Dr. Meenakshi Agrawal, from Roorkee, Dr. Rashmi Rani, Dr. Savita, and from Rudrapur, Dr. Anupama Kutela and Dr. Pavanpreet. So, special gratitude. Ruchi, please stop this flyer from this. So, special gratitude to President Secretaries of all the societies. And before we go on to the program, I invite like a few words from the President Uttarakhand State Chapter, Dr. Meenu Vaishya and Dr. Archana Singh to say a few words before we go for the lighting of lamp.
Good evening, everyone. At the outset, I thank Dr. Sadhana, key organizer, and her conveners, Dr. Ritu and Dr. Amrita, for organizing and involving whole of Uttarakhand for this E-class for cesarean section. So I welcome all my friends, all my seniors, all my mentors, all my colleagues, and all the young brigade for joining this conference. I welcome Dr. Jyoti Sharma ma'am. She is a pattern and she is a great mentor. She is a very humble and grounded person. I welcome Anu ma'am. She is a very polite, humble person and very helpful person. And whenever you have to plan for a conference, she is the menu maker. So whenever you need a special menu, she can plan menu. I welcome all the presidents and the secretaries of the whole of the Uttarakhand societies. I welcome Dr. Manisha, Dr. Anshu. I welcome Dr. Jayashree and Dr. Anushri. I welcome Dr. Sangeeta Singh and Dr. Sujata Pradhan from Haridwar. I welcome Dr. Archana Chauhan, Dr. Sonam Jain from Kashipur. I welcome Dr. Rashmi Saini and Dr. Savita Goti from Roorkee. They are the president and secretary of the Roorkee. I welcome Dr. Anupama Kutela and Dr. Pavanpreet Gill from Rudrapur. I welcome all the speakers. I welcome Dr. Sadhana, Dr. Anjali, and all the chairperson, Sarvetri Madam, Jayashree Tiwari Ma'am, Dr. Sangeeta, Dr. Reena, Dr. Rekha, Dr. Archana Singh. I welcome our moderator, Dr. Ruchira, and the team of our panelists. I welcome all the panel experts, Dr. Aarti Luthra and Dr. Geeta Jain. They will be joining very soon. I welcome all the panelists, Dr. Archana Luthra, Dr. Tanuja, Dr. Archana, Dr. Josna, Dr. Anshu Kakkar, Dr. Anushri, Dr. Savita Goti, Dr. Pavanpreet, and Dr. Sangeeta Garg. I welcome all of you and I welcome all the Uttarakhand people, Uttarakhand members who have joined this conference. Over to you, Dr. Ritu.
Yes, thank you, ma'am. Now let's begin with the auspicious lamp lighting and prayer song. Ruchirji, please play. Thank you. I invite
I
Dr.
just wanted
Sadhana,
to
ma'am.
tell everyone, Dr. Sadhana is for the presidential candidate in 2023. Everyone from Uttarakhand, for every vote, should go for her. Thank you, everyone. Over to Ritu.
Thank you, ma'am.
Thank you, ma'am. Yeah. I invite Dr. Sadhana, ma'am, to introduce our chief guest, Dr. Jyoti Sharma, madam.
Thank you, Ritu. And can I have CV of Dr. Jyoti Sharma? I have met Dr. Jyoti Sharma in last 1.5 years many times. And before I go for her formal introduction, you see, there are few people whose face is their introduction. A grace, dignity, that red bindi, and just now, yeah, in Kolkata ICOG, what a warm relationship she had with Dr. CN, and that photo is something so great, and that is a moment captured. How good she sings. We had a Dehradun meeting, and what lovely she has, that melodious voice and the selection. So something Dr. Jyoti Sharma, if you see, you can never forget in her life. So I first of all, thank you, madam, for being your kind presence as a chief guest and gracing this webinar. So Dr. Jyoti Sharma is practicing as a gynecologist in Dehradun since 1980, past president of Dehradun FOGSI Society. Special interest in infertility and high-risk obstetrics. Won IMA Dehradun Lifetime Achievement Award in 2018, Uttarakhand Chapter Award in 2017, Governor's Award in 2005 for work in obstetric and gynae field. Organized various free camps in Badrinath and Kedarnath, and have participated in various national conferences, and she has been an ardent speaker across various topics. Dr. Jyoti Sharma is like one of the mentor and the mother figure which all of us look forward to her, and there is so many things to learn from her, like her work in the Badrinath and Kedarnath, and she is serving the people who are living in a difficult terrain and doing religious services to so all over the country and all over the world. So Dr. Jyoti Sharma, a warm welcome, and we look forward to hear from you on this occasion.
Thank you so much, ma'am. Thank you so much for your kind words. And I really don't deserve such a lot of praise. It is your goodness, and good people will praise anybody. So I'm just one anybody. And thank you very much for your kind words. And the subject which has been chosen for today, a cesarean section, which is actually pertaining to every lady doctor who's practicing obs and gynae, whether in a big city or in a small town or in a small little rural setup. This is something which, I mean, even if they are not very high up in other highly skilled technologies of this particular line, this every obstetrician should be very well versed with, so that they are not only able to save the child and the mother, but also save themselves from the onslaughts of legalities which are nowadays becoming more and more common with doctors. So with these little words, I welcome each and every person who will be attending this particular symposium today, and I wish Dr. Sadhana all the very best, and we want to see her crowned as the president of FOGSI in the coming year. All the best, Dr. Sadhana. We are all with you. Thank you so much once again for your kind words.
Thank you, Dr. Jyoti Sharma, for your invaluable words and the precious blessings. And with your blessings, we are really committed to work for everyone in our country and bring also the Uttarakhand skill and the knowledge and the expertise and the experience at the national platform. So thank you very much, madam, and we will like to have your expert views till end of the session and your expert comments because your experience matters so much. So thank you, Dr. Jyoti and Ruchir. Please, if you can stop share so we can have one good photograph of Madam Dr. Jyoti Sharma. Yes. So please, Ruchi, Ritu, take good photograph of Madam because.
Yes, ma'am. Yes, ma'am. Definitely. Yes, ma'am.
Yes.
Just a minute. Just a minute.
Click. Yes.
Yeah. Yes. A minute.
Yes.
Thank you, ma'am. A beautiful photograph has come. Yes. Now I welcome our guest of honor, Dr. Anudhir, madam. Richard ji, please play her CV. Dr. Anudhir. Ruchirji, Dr. Anudhir, madam's CV. Yeah. Madam is consultant at PK Dheer Memorial Hospital. She is an ex-Air Force member. She's member of IMA and FOGSI, and she's a master trainer of IPAS, PPIUCD in Uttarakhand. We welcome you, ma'am, and we would be blessed to hear some words of wisdom from you.
Thank you so much for inviting me today to this very common topic. It's a pleasure to be here to hear all this cesarean section, because this is a topic which every lady, every gynecologist is faced with and is doing. And thank you so much to the key organizer, Dr. Sadhana Gupta ji. She is really a doctor, down to earth, a very hardworking, and our best wishes to her for the forthcoming elections and her presidency. Thank you also to the secretary who has been working so hard for this webinar. And the topic chosen today is cesarean section. So we are looking forward for everyone to hear especially the newcomers. They need to know so much about this cesarean section, the difficulties facing them today. Thank you to the president, Dr. Meenu Vaish, who is the powerhouse of training and knowledge, and is always so keen to share her personal experiences. My blessings and good wishes to all the team, the panelists, and all those attending. Thank you so much, everyone.
Thank you very much, ma'am. Now we begin with the scientific section.
Ritu, just a minute.
Yeah.
Go ahead. I pay my special regards and thanks to Dr. Sarveshwari Nautiyal because Dr. Sarveshwari Nautiyal has been something wherever I have been right from my journey. Dr. Sarveshwari Nautiyal was always there. So in Gorakhpur when I came, she was there. In Prayagraj when we did the Vice President Conference, she was there. And all the journey. So my special regards, and how beautifully she is the beloved and sought after person everywhere. And Dr. Nautiyal, what abilities and what the magnetism you have. You are loved at Gorakhpur, you are loved at Ilaban, and you are loved at all over Uttarakhand. And thank you very much for being in life throughout, right from my very young age to this point, and always being together. So thank you very much, Dr. Sarveshwari. It is such a great thing to have you today with us. So
Yes, ma'am. Thank you so much, ma'am. The same thing I would also echo for Sarveshwari Nautiyal, ma'am. Now we begin with the first.
Chairperson, just allow me to speak 2 lines.
Yes, ma'am.
Today is the International Yoga Day. So I must congratulate everybody for this. And this reminds me of Dr. Ruchira Nautiyal's session. Once we had conference in Jolly Grant, and Dr. Ruchira Nautiyal was to conduct a post-lunch session. She started her session asking all of us to stand up and do some exercise and then proceed for the session so that everybody is energetic to listen to her session. So that reminds me of that when the yoga was not popular at that time, she asked everybody in the hall to do some kind of exercise in the post-lunch session. So I remember that, Dr. Ruchira.
It's going to continue for some time.
Yeah.
Thank
We
you.
have
So
been
happy.
attending these yoga sessions for the last 14 days now since the month is going on.
So happy International Yoga Day. So this is a double precious day. It is International Yoga Days, and it is we are with the people of Devbhoomi who have actually must have conceived the first time what is the energy and science and the secrets of yoga. So it is a very, very auspicious day. On behalf of Dr. Meenu Vash, Archana Singh, and all their faculties and dignitaries, we wish everyone a happy International Yoga Day. So thank you, Anushri, for bringing this to our memory. So Ritu, please go ahead.
Yes, ma'am. Now we begin with the scientific session. Session 1, there will be a talk on indication of cesarean section with special reference to Robson's criteria. To grace the occasion, our chairpersons are Dr. Sarveshwari Nautiyal, madam. Ruchirji, Dr. Sarveshwari Nautiyal, madam. Yes, she is the founder and managing director, Kishori Foundation, a pan-India NGO. Previously, she was Director, Medical and Health Services, UP, Director and Senior Consultant and Colposcopist, Regional Cancer Detection, TB Sapru Hospital, Allahabad. And she has got many accolades to her CV, which I would definitely like to mention, but because of the shortage of time, I'm saying that she has the most loving and gentle smile. And I'm really very happy to see her over here, and she's one of my favorites. Thank you. And another chairperson is Dr. Jayashree Tiwari, ma'am. She is the president of Haldwani FOGSI Society. She is in a private practice at Haldwani and has started her IVF center. She has been the vice president of HOGS and has special interest in high-risk obstetrics and infertility. We welcome you, ma'am. The speaker is Meenu Vash, and I would request Dr. Sarveshwari, madam, to please introduce the speaker. Thank you. Dr. Sarveshwari, madam, are you there?
Madam, you are on mute.
Unmute myself. Okay. First of all, I just want to thank Dr. Sadhana, Dr. Amrita, or Dr. Ritu. Why? Because you have picked me up just from Gorakhpur. Okay. I met Sadhana years back. I know how she is, what knowledge she has got, how can and what can she do. So there's lots of to say about the Sadhana. I have seen her starting from the beginning. I want to see her on the top. I want to see her crown. And I give all my best wishes, and whole Uttarakhand is with her. This is for Sadhana. Sadhana, you have said such a beautiful words for me. I don't know whether I deserve them or not. I know Amrita and Ritu, they were just get in front of me and they are growing to a renowned doctor of Allahabad. And I have heard Amrita, she presented papers in many conferences. So I really wish them all the best. I thank Dr. Meenu, our president of Uttarakhand Society. She will bring Uttarakhand in word map. I know she is giving her lectures in national conferences, and now she will definitely go to World Conference to present a paper, and there it will say Dr. Minu from Uttarakhand has come over here. This is I want, this is my desire. And she is one who speaks so well. And I always record her speech, her paper, and give it to her for the correction if she wants to do among us. I just welcome and just want to thank guest of honor and chief guest, my Dr. Jyoti Sharma, Dr. Anudhirdi. Both of are really, they are example for the youngsters in Dehradun in Uttarakhand society. Now, I think I should tell about the Minu Vesh. The only thing I want to tell about her, she's the best doctor at present whom I know in Dehradun, in Uttarakhand. If a girl, if a doctor takes whole of the Uttarakhand with her, she can make the people of the Uttarakhand to follow her. Not only just follow her, to give their presentation in different conferences. She does a teamwork. So I really appreciate the gesture of Dr. Minu Vesh, what she did. I've seen her talking to her patient. I've seen her doing her work. She's one of the ART expert in Dehradun. So just telling about Minu, a good doctor, a very good mother, a very good team member, and a very good person to take her whole team with her. That is a special award to her. And she got so many awards. She got an award from Chief Minister of Uttarakhand for medical excellence. She was past president of Dehradun Society, and now at present she is the president of Uttarakhand Society of Obstetrician and Gynaecologist. This is a big, big society. A whole state is having a society, and definitely she will be giving a chances to the youngsters to show their education, to do the workshop, like laparoscopic workshop, and will definitely benefit the people of Uttarakhand. I will say the people of India. So I have seen her organizing camp at different places, and she always teaches her daughter and her daughter-in-law, be sweet to the patient. This I have heard. So she has got the special interest in high-risk pregnancy, and I must congratulate her. Last paper which she presented in our conference at Meerut, that was superb. Everybody praises her for that. And Dr. Usha Sharma especially said, Minu, you should go forward. You should not stop here. So she is a member of so many committees, and she runs a very good hospital in Dehradun, in which I can tell you 40% patient gets free treatment. That is a credit for her. That's why if anything, any problem, any legal problem comes with the doctors of Dehradun, Minu is always there. So I will not say much about you. I will not say that how many but this is the award.
I don't deserve all this.
You deserve all this. So once again, I thank you, Sadhana, Amrita, Ritu, and my co-chairperson, Jayashri, very sweet smiling girl, and all the Ruchira, full of knowledge. I know her from Allahabad. I know what knowledge she is having. And if there is something which really make us worried, we tell Ruchira, please tell the answer of this question. Please solve this problem. So all the panelists, I know every one of them, and I congratulate all of them to be here in this beautiful, this very important webinar that's on the cesarean section. And the topic which Minu is going to speak about is indication. That is the most important part of the cesarean section. Once again, thank you, Sadhana, and all my best wishes with you. Minu, please, you can start with your
Thank you,
talk.
ma'am. Thank you for lovely and kind words. I'm having tears of happiness. You are such a loving person, and I've been to with you in many conferences. So you are a great mentor, great supportive system. So thank you, ma'am, for the lovely, kind words. Thank you.
Screen.
Amrita, please make me host. I am not the host here, so I'm not able to open my presentation.
Ruchir ji, हाँ. Ruchir ji, please help out Dr. Meenu.
Please make everybody
Madam,
host.
you can share. There is no issue.
Okay. Now I'm able to share. Thank you. So, good evening, everyone. At the outset, I thank Dr. Sadhana Gupta, ma'am, key organizer and the convener and coordinator, Dr. Ritu Srivastav and Dr. Amrita, for giving me opportunity to speak on the topic of indications of cesarean section as per Robson's classification. As we all know, there is a progressive increase in the rate of cesarean section all over the world. And
Madam, sorry to interrupt you. Just put a slide share.
Make it full screen.
The slide is not moving. Slide share mode. Okay.
Full screen जो एक बियर का कप अगर नीचे होगा ना उसको क्लिक करो तो
नीचे है मैम.
It's okay otherwise if it is not happening.
It is readable but her slide is not moving. आप move करके देखिएगा.
Actually, I'll do this.
Click on the
moving like
fine.
that.
Yes.
Okay, I'll be able to do.
It will move.
It's fine. So there was 3 to 5% cesarean rate in 1990, but by the time of 2010, the cesarean rate increased to 30% even in India. So it is of great concern. There is a rising cesarean section rate, and there are various regions in all parts of the world. Worldwide, it differs from city to city, it differs from center to center, it differs from country to country. So we have to find out the regions for increased rate of the cesarean section. And we have to compile the systematic data, and we have to find what are the regions for cesarean section. So rising cesarean section are a major public health concern and cause worldwide debate due to the potential maternal and the perinatal risk. There is increased morbidity and mortality of mother, and there is an increased risk of the PPH, increased risk of the infection, and the cost factors also affected. So there was a classification planned in 2015. WHO statement on Robson classification came in 2015. So WHO proposes the Robson classification system as a global standard for assessing and monitoring and comparing cesarean section rates within healthcare facilities all over the facilities and all over the world. Before going for the indication, it is important to know what is Robson classification. It is very important to know what is Robson classification. It is a 10-group classification, and the classification is simple, robust, reproducible, clinically relevant, and prospective. And it allows the comparison and the analysis of the cesarean section rate within and across these groups of the women. So the Robson classification has been rapidly and increasingly used by many countries all over the world. It is a 10-group Robson classification, and every woman which is admitted into the delivery suite is grouped in one of these Robson groups. And it is very simple to understand. And so the Robson classification is for all women. It is not for women undergoing cesarean section. It is for all women undergoing normal delivery and cesarean section. Every woman admitted to deliver any facility can be classified into one of the 10 groups. And these 10 groups of Robson classification are based on 6 core basic obstetrics variables. And these variables are routinely collected and used in the clinical management of women admitted for delivery. And we can find them in the medical records of a woman. These variables are parity, previous cesarean section or not, onset of labor, number of the fetuses, and gestational age, fetal lie, and presentation. To begin with parity, it could be nulliparous and multiparous, previous cesarean section, yes or no, onset of the labor, whether it is spontaneous labor, induced labor, or no labor, and a pre-labor cesarean section is done. And the number of the fetuses, whether it is singleton and multiple, gestational age, whether it is preterm before 37 weeks of gestation or term 37 weeks or more. Fetal lie, whether it is cephalic presentation, breech presentation, and transverse lie. On these 3 variables, all the Robson classification is based, and the indication is planned according to Robson classification and conventional classification. So now we come to the flow chart of the classification of women in Robson classification. It is very important to understand this. To start with, there is the multiple pregnancy come under the group 8, and transverse lie come under the group 9, and breech presentation in multipara women come under the group 7, nulliparous breech come under the group 6. It is irrespective of the gestation set, parity, previous cesarean or not. All women with multiple pregnancy come under the group 8, all women with all transverse lie come under the group 9, and all nulliparous women with breech presentation come under the group 7, and all nulliparous under the 6 and multiparous under the 7. And now we are left with the patient with gestational age less than 37 weeks with preterm pregnancy. They come under the group 10. How do we understand? How do we learn? There is a method for it. For multiple pregnancy, I draw 2 fetuses. Here we can see I draw 2 fetuses. So it is group 8. For transverse lie, I can write 9 in horizontal way, so it becomes transverse lie. For breech, all multiparous in group 7, all nulliparous breech are in group 6, and all gestational age less than 37, single cephalic and presentation come under the group 10. Now, what are we left with? We are left with group 5, 4, 3, 2, 1. They are all full term, they are term, singleton, and cephalic presentation. They are multiparous or nulliparous. Nulliparous come under the group of 1 or 2, and multiparous come under the group of 3, 4, 5. Seems to be complicated. How do we learn? So here is the method. So all women term more than 37 weeks, singleton pregnancy, multiparous with previous cesarean section come under the group 5. So we can keep this group separate. And there is a trick for 1, 2, 3, 4. We know 1 and 2 are nulliparous, 3, 4, 5 is multiparous group. So there is a trick for 1, 2, 3, 4. We can learn in that way that spontaneous stands for odd number, induced stands for even number. So 4 is an induced labor or pre-labor cesarean section, and group 3 is a spontaneous labor in multiparous women with term cephalic and singleton pregnancy, and 2 is nulliparous women induced labor or pre-labor cesarean section, and group 1 is a spontaneous labor. So spontaneous stands for odd number, induced stands for even number. Here we see 4 and 2 are the even number, so here it is induced labor, and 4 is for multipara and 2 is for nulliparous women, and 1 and 3 stand for the odd number, so it is spontaneous labor. And group 1 is for spontaneous labor in nulliparous women, and group 3 is spontaneous labor in multiparous women. In that way, we can learn it easily. Now we can learn by some example. we performed a cesarean section for fetus distress in a nulliparous woman who had come in spontaneous labor with a singleton cephalic presentation at term. Who will tell this? So she is a term, more than 37 weeks, she is nulliparous, and she is in spontaneous labor. So she comes in the group 2.
1.
And sorry, she comes in the group 1. Thank
Yes,
you, Amrita, for correcting me. And another case, a woman is admitted in 40 weeks of the spontaneous labor with a singleton fetus cephalic presentation. She had 3 prior vaginal delivery. She undergoes cesarean section for fetal distress. Irrespective of her outcome for current pregnancy, she is full term, she is in spontaneous labor, she is singleton pregnancy. She also come in group 1. So she is also in group 1. Next case, we admitted a nulliparous woman with singleton breech pregnancy at 37 weeks for external cephalic version. After successful external cephalic version, we immediately induced labor and she delivered a fetus in cephalic presentation vaginally. She came into delivery suit in breech presentation, but we induced when she was vertex presentation. So she is nulliparous. She is nulliparous, she is term, and she is for induced labor. So she comes in the group 2. I hope everyone is understanding. Now is another example. A woman is admitted in 38 weeks of the gestation with spontaneous labor, with cephalic presentation. She had 3 prior trimester miscarriage. Here I want to give you the message. Miscarriage when a woman has a miscarriage, she is still in nulliparous because all the derivatives, the birth of the baby are less than 500 grams of the baby. So she is nulliparous, she is in spontaneous labor, she is term, and she again comes in the group 1. So these are the different groups. We have already discussed 1, 2, 3, 5, 4 are the term cephalic singleton pregnancy, and they are multiparous or nulliparous. 5 is previous cesarean section, 6, 7, 8, 9, 10 encompass the male presentation, breech and the transverse lie, and 10 is for the preterm. Hope everyone would have understood the Robson class 10 Robson classification. Now we can get this app, we can download this app from Play Store also. So what the facilities have to do, they have to designate a person in charge for the data collection, and he has to produce the Robson report tables at weekly and monthly interval, and they can know whether all the variables are filled in the case sheet properly. If there is classification, all the women are classified in each group properly. It is very important to know. Only then we can put them in respective Robson group criteria. Now we come to now we have got standardized data. The person has collected the data, and we know what is the total number of the women delivered in a hospital. And we can group them 1, 2, 3, 4, 5, 6, 7, and how many women are in each group. And we can know total number of the cesarean section, and we can know the overall cesarean section rate. And we can also know the overall cesarean section rate in each group. And by this, we have got a data, but we can assess the assessment of the data can be done by seeing whether all the data are filled properly or not, or whether the women are classified in a particular group. So we have a quality of the data. We can also know the type of the obstetric population a particular hospital is giving. For example, a small district hospital, a woman in spontaneous labor go. In a tertiary center, in the multi-speciality center, women with previous cesarean section or high risk patient go for delivery. So in that way, we can know the cesarean section, and we can calculate, and we can have a meeting, we can have a panel for all the facilities to reduce the rate of the cesarean section. So we can know what particular population is served by a hospital. Now we come to the indication for cesarean section. In conventional terms, we all know the indication of the cesarean section: previous cesarean section, prolonged labor, prompt, CPD, breech, transverse lie, multiple pregnancy, placenta previa, abruptio or accreta, cord prolapse, fetal distress, and pre-eclampsia, eclampsia, diabetes, oligohydramnios, and second stage arrest, and face, brow, and malpresentation, heart disease, anomalies of the uterus, and maternal request is one of the cause of conventional cesarean section. Now we see the chart here. The second stage 1.2%, for oligohydramnios 5.5, and maximum cesarean section is for fetal distress. The pre-acrita and abruptio and acrita, pre-placenta previa, acrita and abruptio, it is 4.3%. For multiple pregnancy, 3.1%. For breech and transfer, 6.5%. For previous LSC, it is also 29%. So, and prolonged labor, 12.9%, and prompt for 4.6%. CPT is done for 5.4%. So, distribution of cesarean section as per Robson criteria. And nulliparous women with single cephalic pregnancy, more than 37 weeks gestation in spontaneous labor, 17.3%. Nulliparous women with a single cephalic presentation, more than 37 weeks gestation, it is in 23%. Group 3, multipara term cephalic singleton pregnancy, more than 37, it is 2.92%. 4 group, multiparous women with without a previous scar, single cephalic, singleton pregnancy, cephalic presentation, and term incidence is 11.3%. The studies has been done in a hospital in a 2 years. It is a 2 years study, and they have found it. And all multiparous women with a previous cesarean scar, they have a very high rate. It is about 32.76%, and all nulliparous women with a single breech pregnancy, 3.26%. All multiparous women with breech presentation, 2.2%. All women with multiple pregnancy, including women with previous uterine scars, it is 3.08%. All women with a single pregnancy with a transverse lie, irrespective of the gestational age and parity, it is 2.94%. And all women with a single cephalic pregnancy less than 37 weeks is 1.34%. So here we find that the highest rate is when in group 5 we have with the previous cesarean scar. So what the Robson classification is doing, it is identify and analyze the group of the women which contribute most to least of the ovarian cesarean section, and we can find the number of the cesarean section in each group. We can compare practice in these groups of the women with other units who have more desirable results and consider changes in practice. We can assess the effectiveness of the strategy or intervention targeted at optimizing the use of the cesarean section. So we can assess the quality of the data collected and raise staff awareness about the importance of this data and the interpretation and the use. So various studies have been done. The studies was done in June 2014. They concluded the use of the Robson classification is increasing rapidly and spontaneously worldwide despite some limitation. This classification is easy to implement and interpret. Several suggested modification could be useful to help facilities and countries as they work towards implement. There's a lot of limitation in Robson classification. It doesn't include fetal distress. It doesn't include placenta previa. It doesn't include high risk pregnancy. So modification is definitely needed. Another study was done in Journal of the Nepal Medical Association. They have in 2016, the study showed that the prevalence of the cesarean section, which lies in the Robson group 2, where the labor is induced in nulliparous women, and higher than the standard in World Health Organization group. It showed that the Robson group 2 was one of the significant contributors in the greater cesarean section rate. Improved case spectrum standardization and the protocol for induction of the labor, as well as regular audit, could also reduce the cesarean section rate. So another study was done in Medical College Hospital in Gujarat, and the result indicated that the group 5 with previous cesarean section, term cephalic with previous cesarean section, Women with previous cesarean section and group 2 women with induced labor contributed the maximum to overall cesarean section rate. Trial of the labor after cesarean section could be used as a routine. The specific guidelines should be followed about the time and the cause of the induction of the labor to disease. If there is a previous cesarean section, we should try for normal delivery too. To monitor cesarean section rate and take action accordingly, Robson's 10 group classification should be used in all health facilities where delivery is done. So the further studies was done in 2021. It is the original research indication for cesarean section as per Robson criteria. An analysis of 5,000 consecutive cesarean section was done. And they have concluded that as per Robson criteria, group 5, previous cesarean section remains the main indication for cesarean section, 33%, followed by group 3, where the nulliparous women, where the labor was induced. So it is 23%, and group 1 nulliparous with spontaneous labor 17% respectively. And the group 1 and 2 indicate cesarean section in nulliparous women. And in transverse lie and cesarean section, all patients underwent cesarean section. So we reach to the conclusion. So Robson classification is a very important landmark. It can work as an audit tool to report the data in systematic manner so that all the criteria can be compared to find the reason for rising cesarean rates. And we can decide the indication of cesarean section. It helps to identify the groups that have greatest impact on the cesarean section rate. It also helps to develop a strategy focusing on the reduction of the cesarean section rate by corrective intervention. And all these slides have been taken from the implementation manual of Robson classification, WHO implementation manual. So thank you very much for patience hearing. Hello, Aarti.
Hi, ma'am. Hi.
Thank you very much, ma'am, for your detailed and informative talk. And now I request Dr. Jayashree Tiwari, ma'am, to give her concluding remarks.
Good afternoon, everyone. First of all, my warm regards to all respected dignitaries present here, especially Dr. Sadhana Gupta, most promising presidential candidate, Dr. Jyoti Sharma, today's chief guest, and Dr. Anudhir ma'am. She is the guest of honor of today's. Thank you, Dr. Meenu. So you explain so in detail, so easy manner. You explain all the groups. I think all they are listening this, they all remember this group in first word, in second word. So it's so easy method you tell us, and you told us that cesarean section rates are increasing day by day in both developed and developing countries. And Robson's 10 group classification system, it is an emerging tool to evaluate the rates of cesarean section and perinatal outcome. Because of its worldwide acceptance, in 2017, WHO launched Robson's classification platform. This global free platform is a place where individual maternity unit can upload and share hospital level cesarean and associated perinatal outcome data using Robson's criteria. According to Robson's criteria, you told so many times that group 5 is the most common cesarean section case, maximum cesarean section in previous cesarean section, and second one is group 2, nulliparous not in labor. These are the most common. Nothing left. You explain everything in so detail. What should I told? I don't know. So this Robson's criteria, we should try to inculcate in our day-to-day practice. By this, we will be able to reduce cesarean section rate. And it is especially advantageous for PG students and upcoming gynecologists. And I think all the doctors, they are listening, all should start implement this Robson's criteria in their hospital. By this, we will be able to reduce the cesarean section rate. And the data by this Robson's
criteria platform. We can be used for multiple purposes, including monitoring and comparing trends of cesarean section rates, maternal and perinatal outcome, evaluation of impact of intervention to optimize cesarean section rate, among others. So thank you, Dr. Meenu, again for such a wonderful session. Thank you very much. You explained so interactive, so informative, so wonderful session. Thank you very much, ma'am.
Thank you, Dr. Jayashree.
Thank you.
Dr. Jayashree.
Thank you,
Just
ma'am.
Meenu, excellent talk, and what you brings like one of the very thing that is EV not that never came to our mind to remember. So this is something very important that EV not we can remember. And one thing I will say that the audit of cesarean section is bound to come. So it is very important that when we do our like OT register, we maintain it, make it that it is a what it is a primary gravidocephalic presentation or it is a transfer slide, because any time because in Odisha, in many states, Andhra Pradesh, there is already the government audit is a something a must to do. And I like appeal to every obstetrician who are having any like a whatever number of cesarean section in OT register, make the report that it is a criteria. It is nothing something like a inquiry or something, but whenever we have the things in place, we have to things that this is our indication and that's it. It is nothing to blame that you take this decision or not, but if we do that data in our OT register, and it is not that difficult what Meenu have said. So it is time that we are already prepared before any media or anything point to us. So thank you and excellent talk, Meenu.
About just I want to add over here, like Dr. Sadhana said, documentation is must. That is the only part which can save you. And I'm so happy now. I have not seen the indication of obstructed labor in cesarean. It means that follow-up of the patient is so good that she doesn't come in obstructed labor. She come for the cesarean section because indication are already told to her. So documentation is the best policy to save yourself. Thank you.
Thank you, ma'am. Now it's time for the panel discussion. The topic is
Ritu, Dr. Aarti. Dr. Aarti has raised her hand. She wants to say
also
something.
say yes, Aarti, a warm welcome, Aarti. It's always like so great to have you, and we always remember Dehradun meeting with a great cultural program. Ritu, just check Dr. Ruchika is there or not, so that if she is not available,
I just wanted to say a few words about Dr. Aarti and Dr. Sadhana. Dr. Aarti and Sadhana are from the same college and they share the same date of birth. So that's a great thing. That's a great combination.
Thank you, ma'am. Thank you for remembering that. A very good evening, dear Sadhana ma'am. And we appreciate your efforts to spread the knowledge. That's why I had raised the hand. And this webinar, although the topic looks common, but it is so important because all PGs and at every stage of a gynecologist's career, C-section is one thing which we need to revise. And Meenu ma'am's talk was really nice, very crisp and clear regarding Robson's criteria. And as suggested by Sadhana ma'am, I think all of us should start noting down the indication in a proper way so that whenever government passes a notice, the way now we have to justify the hysterectomies which we are doing. So if we start collecting the data, it will not be a burden on all of us. Thank you, ma'am. A very good topic and excellent talk by Meenu, ma'am.
Thank you, dear.
Yes, ma'am. Dr. Ruchira is there. Dr. Ruchira Nautiyal is there, ma'am. Yeah. Now let's move on to panel discussion. The topic is difficult situations in cesarean section. Moderator is Dr. Ruchira Nautiyal. Can I have a CV? Dr. Ruchira's CV, yeah. Yeah, she is professor and head at Himalayan Institute of Medical Sciences, Jolly Grant, Dehradun. She has published over 35 papers in various journals. She is a National Resource Faculty for STI and RTI. She is a trained laparoscopic surgeon, and she is a scientific coordinator for Uttarakhand Chapter of FOGSI. We welcome you, ma'am. Our experts for the panel discussion are Dr. Geeta Jain. Madam is Professor and Head of the Department at Government Medical College, Haldwani. She is ex-President, Haldwani FOGSI Society. She is Master Trainer for EMOC. She is MCI Inspector for Recognition of Graduate and PG courses. And she is member of Ethical Research Committee. Our panelists are Dr. Jyoti Bora Pandey, Dr. Tanuja Bora Pandey, sorry, I'm very sorry. Dr. Tanuja Bora Pandey. She is consultant obs-gynec and laparoscopic surgeon and infertility specialist at Pride Hospital, Haldwani, and she has a fellowship in IVF technique. Then Dr. Archana Singh. She is senior consultant at Naveen Hospital and has expertise in hysteroscopy and colposcopy. And she is vice president of Muradabad Society and consultant at Archana Hospital. Welcome. Dr. Archana Luthra. She is ex-president. She is ex-president FOGSI Dehradun, and she is a gynecologist at Archana Hospital. And she is a she has joined many conferences. Then Dr. Jyosna Agarwal. She is secretary of Roorkee FOGSI Society and credited for designing Roorkee Society logo, and is ex-member of Uttarakhand SOG. Then Dr. Anshu Kakkar. She is Associate Professor, Sri Guru Ram Rai Medical College, Dehradun, and she is Secretary, Dehradun Society, and she is Secretary, International Society of Gynae Plastic Surgery. Welcome. Dr. Anushri Rawal. Dr. Anushri Rawal. She is consultant at Anurjun Multi-Speciality Hospital, Haldwani, and she is secretary of Haldwani Society. She has special interest in high-risk pregnancy, laparoscopy, and urogynecology. Then Dr. Savita Goti. She is secretary, Roorkee FOGSI Society, and is working in St. Joseph's Hospital. Then Dr. Pawanpreet Man. She is consultant at Amrit Hospital, Rudrapur, well-known laparoscopic and vaginal surgeon, and she is founder and president and present secretary of Rudrapur Society. Then Dr. Sangeeta Garg. She is consultant gynecologist and obstetrician at Sanjeevan Hospital and has been secretary and president of Roorkee FOGSI Society. We welcome all the panelists, experts, as well as the moderator. Then over to you, Dr. Ruchira, for moderation.
Thank you, ma'am.
Mute, unmute,
You are not audible.
unmute.
You are still not audible.
Ruchira, not audible.
You are on mute only, but your speaker, I think, doesn't responding. No, you are not audible.
Unmute herself.
You unmute only.
Ruchira, you have to check your speaker setting. Try to use a earphone if it is there, because sometimes we have this problem. Or if you have the slide share, then you can join from mobile and slide share from this side. Geeta is with us, if you can share. So you can, anybody from this side can slide share. and you can like join from the mobile. I think
you can also send me. I can slide share and you dictate from mobile.
Try to join from mobile. So if it is audible from mobile, then we can have this backup.
Meanwhile, can we take the third talk? I mean, the talk, if Dr. Ruchira allows us.
Ma'am, I just called her up. She has some problem because she has unmuted from her own self. But there's some
that's why I say. That's why I say.
Yeah, this is what I was also telling her, that you make yourself visible on the screen. We'll be able to help you out there.
No, we must have the presentation so Ruchir can. Like,
she has already sent the presentation, ma'am.
So Ruchir, you can go ahead, na, with if she sent. But then she has to join from mobile actually. Dr. Ruchira, if you join from mobile, then we will be able to listen. अभी नहीं audible है. No, you are
अभी audible नहीं है, and who she sent them? I have not received.
She told me just that she's already sent it.
Hello, am I?
Yes.
Yes, you can.
Yes.
Mute
the audio of your laptop.
Yeah, just did.
Yes.
Still, audio of your laptop, not speakers also.
Why the two laptops are there? That's why the voice is echoing.
Yes.
Nearby some other
लैपटॉप बंद कर दीजिए.
लैपटॉप बंद कर दीजिए.
लैपटॉप बंद कर दीजिए.
पर फिर मेरी स्क्रीन कैसे दिखेंगी? मोबाइल बंद कर दीजिए.
मोबाइल से आप ज्वाइन कर लीजिए. मोबाइल से ज्वाइन कर लीजिए and you send the presentation.
Please send the presentation to me. I will showcase, and you can take the presentation from your mobile.
No, it is not audible.
Ma'am, should we go to the talk, the second talk?
No, we have to take
by the time
permission from Dr. Ruchira.
Because Ruchira has to leave.
Dr. Ruchira said that we doesn't because
we can't hear you, Dr. Ruchira.
On your mobile.
How do I see my screen?
Somebody will display for you.
We will display it for you. We will display it from here. Ruchira, you.
आप मोबाइल में देख सकोगे. Yes.
Good.
Yes.
Great.
Dr. Ruchira, now you join from mobile and.
But madam, my voice will echo.
Madam, Ruchira madam, can you listen to me for 1 minute so this problem will be over? Your volume of the speakers means from where you listening should be off laptops. You put speaker of the laptop mute.
I did that.
But now the echo is
It's gone. Yeah, echo is gone.
Can hear you.
Yeah, good.
Yeah, it's good.
Well done.
ironically, calm seas never make a skilled sailor. और ये पहली साइड से साक्षात हो गया. So, but we all are hardcore obstetricians from the heart. No matter, my panel includes a good mix of laparoscopists, urogynecologists, oncosurgeons, but we all love to be obstetricians, and that's why we are here. So without taking much of the time, if we talk about the cesarean section, we know it is the commonest surgery day in and out, and over the years, over the decades, we have been doing that. But everybody can vouch for that. You can have a nightmare right from the word go. So the challenges one can face can be from the entry into the abdomen, especially if you have a scarred abdomen. And it is really a challenge. We will see how our panelists help us with that. And then we know we are all on our three sides. We are surrounded by Pakistan, China, and Bangladesh. So we have to. Then once into the abdomen, then entering into the uterine cavity, placing a beautiful scar, it could be a challenge because of the presence of fibroids or adhesions, and difficulty impacted head as in labor or in malpresentations or Mullerian anomalies. So these are the various challenges that we will be seeing how our panelists help us with this today.
Madam, you are putting
maybe
yourself.
encounter an anterior located placenta.
Madam,
placenta.
one second. Yeah. You are putting yourself mute because you are holding the mobile yourself. You keep a mobile on some stand or something, because while holding your mobile, you are muting yourself in between, so the clarity of the voice is not there. Right now, it is mute also. It is mute right now.
Hello. Am I audible, Mr. Ruchir?
Yeah, you are now audible clearly.
Right.
You do not, hold the mobile. If you hold the mobile by mistake, you are muting yourself.
Okay. Right. So what I just want to say is the last part of it, the hemorrhage part, I am not including because it by itself is a webinar. And so we would deliberately avoid this today, and we will deal with the other things. So this is the first case of the day, where we see a patient who is third gravida with previous 2 C-sections, and she is at term. She is one with a BMI of 32, so she's an obese patient, and we can see how her previous 2 cesarean sections have been. They are midline infra-umbilical ones. So the first question, if I may ask Dr. Archana Singh to take up. Madam, looking at the case, how do you choose and plan your abdominal incision, and why? And what are the precautions that you would take? Archana Singh of UP or Moradabad, both are welcome, or any of the two.
I think she has not joined.
Archana
has not joined.
Singh is there. Archana Singh is there.
Dr. Archana Singh. There are 2 Archana Singh. One is from UP, Moradabad,
and one is from Uttarakhand. She is the secretary of
Haldwani. Yeah. Archana is there. I'm seeing her.
Dr. Archana, you can just take up this. See, we all want to see each other's experiences and learn.
I'm Dr. Archana Luthra. I have this question for you. This patient who had previous cesareans and had a vertical cesarean, and she has high BMI, and she's of now. Is that the situation?
Madam, you're not very clearly audible. I'm sorry.
My question.
Answer this
Dr.
question.
Jyoti, can we start with you? Dr. Archana, hi. Would
Hi,
you like
ma'am.
to?
Yeah,
I know.
actually, I was not supposed to join the panel, but definitely I share my experience.
Yeah.
Uh,
This
in
case,
this,
how do you, we have a previous 2 midline cesarean. Now, what do you plan for her? She's your patient at home.
see, ma'am, because I am a little bit more towards cosmetic part of the surgery, so I will take this again from the midline. I won't give her another scar in this case, and I will definitely regarding the precautions,
right.
I have to see regarding the whatever adhesions I may face. I may find bowel just below it. I may find accidentally I may stab the uterus also directly.
So, what precautions do you exercise?
So I will definitely gradually go layer by layer. I will try to see whether there are what are the underlying structures there. I will not take it in a go. I will try to move a little bit slow in this case. I will remove the scar and then slowly go into the deeper structures. I will take the rectus itself separately and the peritoneum separately if I can, because here I might be going through both the layers in a go.
Yeah. So you would like to take up a sharp dissection or a blunt?
Excuse me, ma'am?
A sharp dissection or a blunt one?
I will go through a sharp dissection, not a blunt one.
Okay, so good. You mentioned you do not want to give her another design or scar on the abdomen, and well accepted, you want to enter through the same midline incision. Anybody, Madam Luthra, or anybody would like to have a change or a different opinion here?
Yes, ma'am. I want to go for transfer.
May I know?
Yes, ma'am. I am Dr. Sangeeta Singhal.
Yeah,
I would
madam.
like to go with the transfers incision.
Transfers. Madam, why your special liking for transfers?
When she is very obese patient and previous to LSCS, so it would be better for me to go with the fan and steel incision.
Fan and steel incision. Okay.
Yes.
And then layer by layer?
And less chance of hernia also in this case if I go with the transfers, and approach will be easier for me.
Okay. Yeah. Actually speaking, one can enter through either of these, as the evidence also says, that you can choose a midline vertical or you can choose any of the transfers, be it the fan and steel or be it the Misgab Ladakh technique of Joel Cohen, which is less of sharp and more of blunt in primary cesarean. But here, since it is previous to, definitely more of sharp dissection. So as Dr. Sangeeta says, because one may go along the transverse incision as well in this case. And surprisingly, as we see, even those who are morbidly obese and BMI more than 40, the literature says the wound infections and wound complications, they are comparable. What one has to pay attention to is, in giving a transverse incision, is that here we do not take umbilicus as the landmark, because obese, the umbilicus may be low down. So we have to design our incision from anterior superior iliac spine. One has to assign an assistant to hold the panniculus. Sometimes it just falls on it. So you have to keep that fat away, retract it, and try to make sharp cut, not those superficial strokes. Sharp, bold cut in the skin, in the center, but just above the crease, so that it is not wet and humid out there. And once the skin is opened, then the subcutaneous plane also has to be taken up in a bold cut. Avoid those multiple sharp cuts in the fat plane, because that will create a dead space. And for the rectal sheath, you can go laterally, or you find a space upwards. That is what most of us do. One may go for inner transverse incision because here we know the space would be less. She's previous to and obese. So you might have to exercise the muscles also, which becomes a malar. But in that case, we all know some inferior epigastric can be treacherous. So just watch out for that. So the bottom line is, as Dr. Archana said, you go by your midline as she chose. One has to enter through a virgin area. Try to pick up a part which is above the incision or a bit away from the incision, and then maybe a peep through and you can enter. Once you enter the abdomen for peritoneum, either ways, a blunt or a sharp, you just palpate it, hold it, stretch it, blunt or a sharp. The vast trial on over 14,000 women, Coronus trial, they have come up with the, again, an insignificant opinion. They say any of the blunt and sharp dissection is good enough, as long as you are watchful and you follow the principles. So yes, both the panelists, they are differing in the view and both are welcome. One cannot prevent the adhesion barriers, they do not help. Only gentle, meticulous handling of the tissue, hemostasis, they are the best adhesion barriers. And one thought about the time taken. I need to tell here the time from the opening of the abdomen, delivery of the baby doesn't matter at all. It is the time from placing a uterine incision to the delivery of the baby, which is actually important, as we will see in a couple of slides later. So one may take enough of time and be safe in entering the abdomen. So now we have safely entered the abdomen. Madam Luthra, as expected, we know bladder will be all pulled up here. So how do you deal with that? And give us your tips on that. And then what will be your incision as you find a limited space in the uterus? How do you place your incision? Uterine incision.
So very careful about the bladder every time. And we have to sort of be prepared for situations where we can encounter the bladder while opening the abdomen. And those situations could be like a patient who's had previous cesareans, a patient who had peritonitis, who was operated for appendicitis, or had previous surgeries on the uterus for whatever reasons. And placing a Foley's catheter preoperatively, I find, is always a good idea.
Right, right. So how do you dissect? Bladder is right there.
Bladder is right there. We start from above. We start opening the peritoneum from above. And always we are looking through the peritoneum to see where the bladder begins. And we can go vertically upwards rather than going downwards towards the symphysis pubis.
So how do we identify this would be the limit of bladder?
First thing is, when we are opening the peritoneum, we can see the translucency goes down, and the suprapubic, supravesical fat is one signal which warns us that nearby.
Yeah, right.
Essence
Truly speaking,
belongs to bladder. It is said, no, that
always, right, madam. And then you would use, of course, sharp dissection. Isn't it, ma'am?
Of course, dissection with small nicks, and like each and every nick that we give, we should be sure about what we are cutting.
Okay, because your aim would be to that the uterine incision should always be a
little
smiley.
And
it is higher, but then
yeah, if it's a priming who's undergoing a cesarean, we should make sure that the incision is lower down, because every subsequent cesarean, we would have to move a little higher up. And the incision, instead of being transverse, it should be a curvy linear incision.
Curvy linear incision, right, right. So as we see, of course, the incidence of bladder injury, we see it keeps rising with the repeat cesarean, and almost half of the cases, the bladder gets damaged when just opening up the peritoneum. So one has to be very, very careful, as it might be pulled up. You rightly said it is the fat that warns us, and be it the dome of bladder, which is injured in a first cesarean, or trigone of body.
Most of the time, it is a dome, it is
entire world comes to know when the bladder is injured. So best is prevention. So always use sharp scissors, small sharp snips. Stick to the uterus as much as possible. And one thing is, whenever there is a doubt, we always do that. Sometimes a good practice point, once the baby is out, you can go for a retrograde check for the integrity of the bladder. And important thing is, if at all there is an inadvertent injury, it is mandatory to call for help, a surgeon or a neurosurgeon, to avoid any medical legal hassles. So that is one important thing that one must pay account into. And as far as possible, we see the rupture uterus incidence. Try to make incision in the lower segment. If needed, you could extend it, but never place lower verticals or anything, because we see that increases the risk of rupture in anytime. Although she is a third cesarean, we would be doing a sterilization with us for her. And this is the time we know the time between the uterine incision, if the time taken is to the tune of 4 minutes or more, then that is associated with adverse perinatal outcomes in the form of fetal acidosis and poor Apgar scores. So I'm sure by this time, nobody generally takes us more than a minute or two. And this is the time which is important, and not the time from skin incision to entering into the abdomen. So thank you, madam. Dr. Jyotsna, continuing with this case, all hail and hearty so far. Do you think there is any difference in closing her abdomen up? Dr. Archana has opened her midline, the same scar thrice. So, and would you like to take up fat as a separate entity, close fat down, or any time if it is a transverse? Have you ever placed drains?
Ma'am, I mean, abdominal closure, the difference is, first the rectus entity has to be done, and the third is a third section and vertical incision. So sometimes we don't get definite planes. So peritoneum, rectus sheet, muscles, even muscle is very thin in such type of patient. As we are going, she's obese, multigravida. So we have to do a single layer closure. So what we have to secure the angles of the rectus in a very nice manner. So maybe we can use 2 different sutures for taking the angles as per. And then otherwise we can do a continuous stitch of the rectus. That's what is recommended. And as for the fat is concerned, if it is more than 2 centimeter, then it is recommended. It is said that when we close the subcutaneous layer, the basic idea should be to close there should be no dead spaces. Better the apposition of the space. So why we are doing it? We are basically doing for maintaining the integrity of the skin incision. So fat layer is to bring the skin together. So the apposition of the skin is better. Drain as per the evidence says no. But sometimes clinically, practically, we may put it, but it is not recommended. For drain, there is no evidence-based support to put a drain in fat.
Right. I'm so happy, Dr. Jyotsna, you've covered all the relevant points. So although we gynecologists are not very used to doing a mass closure, but then we need to learn it from our surgeon friends that all in one layer is a good idea. What is more important, rather at most important, is integrity of rectus sheath. Here, the important point is non-locking. हम लोग कहते हैं खींचो और जोर लगाओ. That doesn't work here. It is just the approximation. Rather, you can take up a couple of interrupted stitches if required, and that is relevant. Fat, unless until it is too thick, as you rightly mentioned, and keeping in a drain or negative suction, it really doesn't help in breakdown of the wound, and therefore it is not recommended. So nicely brought up, Dr. Jyotna. Thank you. So now we come over quickly to the second case, which is IVF conceived primi gravida. And unfortunately, most of the IVF one they land up with some or the other problems. So this one, she came at 31 weeks to your facility with preeclampsia with severe features. Her presentation is a longitudinal one, transverse lie. You did all the necessary workup, investigations, you give all the therapy, mother, Maxal, Dexa, and fetal magnesium sulfate and all. She was there for a day or two. And now considering maternal indication, she is to be taken up for C-section. So Dr. Anushri, if may I ask you, Dr. Anushri?
Yes, ma'am. Yes, ma'am.
So you are a busy practitioner. So you thought this is main to bach gayi. This is not a previous to the last case. So can I ask my junior or my second in command to take up this case as she is a primary cesarean, or you will want to take up this case yourself, anticipating some problems?
No, ma'am. Transverse lie can be very hazardous. If first of all, I would like to ascertain by ultrasound or anything, if it is not a complete placenta previa, the cause of the transverse lie needs to be seen. If it's because of a septate uterus or a placenta previa, because in that case, I will have a lot of vasculature in the lower uterine segment. Plus, she's a preterm. She's preterm, and I would also like to see if there is at times when we open the abdomen, we have abnormal vessels on the surface of the uterus. So many a times they need to be tied up, and I don't think anybody who has less knowledge or less experience should handle such cases. However, that being said, I am also not very experienced. But that being said, you should always have somebody in hand because whenever you do a transverse lie, if you are not confident, though I have done lots of transverse lie with placenta previa, but if I am giving it to my junior, I would not give it to my junior completely.
I'm glad you brought up this, that you would like to have somebody senior. This is a very pertinent point. One knows
it's not directly with me. At least, if I know, if I'm anticipating something, I should have somebody to help me out. If I know I can't handle it on my own. I'm not talking about just myself. Anybody, any gynecologist, and especially like many a times you're doing it in the night or you're doing it, yes.
You said that you will like to see for placenta. So
Definitely.
What more would you like to do? She must be carrying a scan for placenta maybe. So is that enough?
Yes, of course.
Further you want to see
something?
No,
ma'am. If a placenta is anterior, I would definitely like to go for an MRI to rule out accreta. If
okay, now let's leave that. Placenta is upper. Placenta is upper body.
Okay. Placenta is upper body. Transverse lie hai, ma'am. Okay, I would, though I know as the literature says that in preterm pregnancies, preterm deliveries, you give a vertical incision also, but I would go with a lower segment transverse incision. And then I would deliver the baby by breech extraction, ma'am. I would follow the shoulders. I would follow the shoulder and the back and the back. From the shoulders, I'd follow the back and take out the baby by breech extraction by holding the feet
Okay. So what is an important message over here is somebody has to be really vigilant and an expert in handling these cases. And then an important thing I need to say is, because other than the placenta, one has to, these babies are delivered as breech. So you have to see where the head is, where the feet are and the back.
Yes.
So if the back is superior, you can just go along the back and bring down the feet if it is dorsal superior. But if it is dorsal inferior, it can be very tricky. And the small parts, they all appear to be one. So you can't just be playing inside. So one has to do the scans yourself or assess clinically where the head is, where the back is, and the feet is, along with the placenta. So that is an important point. You have to modify your incision, because the lower segment is not formed, it is preterm, and it is said that one may place a vertical incision low down. I'm not sure.
Yes.
One would
Yes,
like
yes, same here.
always to place the transverse incision, because you never know, the extension down can be treacherous. So there is one thing, if during surgery, the cord, umbilical cord, it just starts popping out. So would you like to do something with it?
Just,
ma'am, I would consider delivering the baby because we are in cesarean section. Yes, and the cord, we should not waste time in repositioning the cord. That is.
It is never reposited also, because itna karoge, it will keep coming out.
Yes, you can't do
So
it and you can't move it out of the way. So we should focus on delivering the child. And
the baby
if need be, and if need be, we can extend that incision to vertical or whatever J shape, whatever when we face such complications, then whatever works to deliver the baby has to, and taking care of not to do overextension at the head when we are delivering the breech extraction, and not to overstretch the limbs as well as the shoulder. So
thank you. The baby is always delivered as breech extraction. I support always a lower segment incision and not a vertical incision as far as possible, but try to do the preliminary work yourself. And especially if it is sometimes transverse lie with no liker, those are the toughest C-sections. So one has to be really vigilant in not giving a trauma to the fetus and delivering the baby deftly. So
just two things I would like to add, ma'am, Ruchira ma'am, that we have to anticipate PPH and we have to anticipate Mullerian abnormalities if it is a transverse.
Yes.
These two things, and PPH, we have to be really cautious. We have to keep everything ready, because with transverse it may go in atonicity, and Mullerian thing is something we really need to see, because it could be
I was coming to Mullerian part, which you have rightly brought down. और PPH तो हमारा पीछा छोड़ेगा ही नहीं ना, इसलिए आज मैंने उसको छोड़ दिया.
These are the cases who are like, we have to anticipate.
Very prone to PPH.
Yes. So we have to be ready for, like, now carbetocin is there and everything. So the PPH drill has to be your.
Ma'am, this has happened with me. One of my own relatives I have delivered. I was alone in the OT and she was 35, 36 weeks. She went into labor. She was a transverse lie with a septum and she had such terrible PPH. So I know it is very transverse lie with septum and PPH is really bad.
As you just said, like, she was
you have to anticipate.
So, septum and
yes, true. I agree.
Something we have to see. We are just having this webinar just to revise these points only. That is.
Yeah.
So happy, Dr. Jyotsna. And so glad you are bringing these small relevant points, and please keep doing that. Okay. So thank you so much. Dr. Sangeeta Madam, Dr. Sangeeta Gar, it happens some of the times that you've shifted this patient in the OT because the patient was there for a day or two, and now there is a version on itself, and it is a cephalic presentation, since it appears to be an unstable lie. Which does that make you happy? And how do you deal with this now free-floating head, 31 weeks? Dr. Sangeeta Gar.
Hello, everyone. If I come across with this patient, I would be happy in a cephalic presentation, but because it is a free-floating preterm head, so there may be difficulty in catching this head, because uterine segment is not formed during the preterm period, and there may be considerable difficulty in feeling floating head. There may be some traumatic or extension of the segment incision. So first we should, patient is already in OT, if this patient comes before pains,
membranes not ruptured. Membranes not yet ruptured. She's on the OT table. It's just that the presentation is changed.
Presentation is changed. We should rule out the placenta also, placenta previa or any placenta accreta, because free-floating head can be in these conditions. And first we should allow the drainage. We will give the incision in the lower segment, and we will allow liquor to be drained out completely, because it helps in the lowering down of the head. And a small floating head, so we should ask the assistant to stabilize the baby by holding down the side of the abdomen and apply fundal pressure to push the floating head as low down into the lower uterine segment. sometimes these two methods may be successful, but if it is not successful, then we can go for the forceps application, outlet forceps application. We can apply, and for this,
have you
first,
tried forceps?
pardon me?
Excuse me, ma'am. Have you tried forceps in free floating head? And if yes, what is your experience? Have you used a single blade or two blades?
Yes, double blade. First, we should fix the baby head, floating head, and should the head in our hand, and then we should fix the blades, and posterior part of the blade we should insert inside the uterine cavity by giving support of our fingers, and then apply the second blade on the interior wall of the uterine segment, and we should lock and check the lock properly and try to give the axial traction, and slowly baby can come out. If forceps are not available, or we are not comfortable with the forceps, or it's not available, and your baby is small, it can go upsides or fixed with our hand, then we can go for the internal podalic version. This measure for this, we can go for the find out the heel of the baby and catch the heel of the foot of the baby, and we should pull out the baby and trunk first heel, legs, and then trunk, and can be drained out. And if baby is not too premature, or it's about 35-36 weeks of preterm baby, we can go for ventral suction.
Yeah, but this one, we'll come over to that. This one is a preterm. So
Okay,
you
okay.
very rightly mentioned. So first of all, you said what is convenient to you is giving a small incision, allowing the fetus to descend through that small hysterectomy, the liver to drain, and fix it with an assistant from outside, right?
Yes.
So, anybody, Madam Luthra or Dr. Anshu, have you tried a single blade, or do you think single blade or a double blade works over here? Dr. Sangeeta has rightly pointed out.
Single blade can also work out.
Madam Luthra, please unmute. Please unmute, Madam. Luthra, ma'am. Unmute yourself. You are muted. Madam, you are muted. Madam, we can't hear you.
Yeah. See, if the space is very less, using a single blade is always a good idea. If we are very sure about where the back is, and we can just put in a blade and just deflex the head a little, it would pop out in the incision and we can take out the baby. But my preference is always for a vacuum extractor in such a situation.
Oh, but this is a preterm head, madam, so vacuum we can't be using here.
Yeah, anything 34 weeks, I would not use a vacuum.
So we have to use, so in this case, if it is preterm, of course, either manual delivery. What I want to bring forth is, for free floating head, a single blade doesn't work much. It works beautifully for a deep head. Here one has to generally steady the head and make it in a cage and help maintain the flexion. So both the blades are generally used here, and Dr. Sangeeta was right. If it had been a term head, then one would have gone for vacuum. Remember to maintain flexion of the head at all times. And if you think it is free floating and the lie has gone all topsy-turvy, then catch hold of the feet. It is always easy to, दूसरे की टांग खींचना आसान होता है, सिर नहीं पकड़ा जाता. So internal podalic version and breech extraction would be a safe choice if there is any doubt about the expertise in instrumental delivery. So for forceps application, what is important?
Ruchira, I would just chip in a line. वो हम लोग सिखाते थे ना रुचिरा,
जी मैम,
something रुचिरा,
जी मैम, जी
हेलो, या जैसे हम लोग को सिखाते थे ना कि अगर बच्चे का सर ना पकड़ में आए ना तो पैर पकड़ लो. So अगर if you are unable to, Yeah, that's what you have told कि मतलब breech extraction would be the easiest. यही कहते हैं ना कि अगर सर ना पकड़ना है तो पैर पकड़ लो बच्चे के. So you can do a breech extraction. Yeah.
Exactly. That is one always convenient and the easiest way and non-traumatic way to deliver the baby out.
The best and the easiest way. And another thing is जो forceps रखते हैं तो वो anterior posterior लगेंगे. Normally हम लोग जो लगाते हैं ना, हम forceps लगाते हैं right और left side लगाते हैं. और जो section में forceps रखते हैं वो anterior posterior करके लगेगा जैसे OP में लगता है. So these things I just wanted to bring up. Yeah.
Yes. So thank you so much. Lower blade first. Fetal का head sagittal में होना चाहिए because blades होंगे. Remember, it is a cephalic application. Head के हिसाब से लगेंगे. Anteriorly and posteriorly. And the curve, the pelvic curve is towards the occiput. और occiput का पता कैसे चलेगा? Back से. So wherever the back is, you know that is the occiput, and accordingly you will place the forceps. And those who are experts, they are most comfortable with it. And otherwise, rightly said, leg pull करके bring down the fetus and deliver it out. And just for the sake of completion, we know it could be a term mobile head. And there comes the vacuum, which is in fact used as by so many of the obstetricians I have seen in various conferences. And this one has come up as a handy tool where you are the one who are operating the entire suction. So I just got this video from the net. So I thought half a minute, rather a 30-second video. We can see it is available on the internet. They place the kiwi cup. It is a cup near the occiput at the flexion point, ahead of the posterior fontanelle, not anterior, posterior, to maintain flexion. And you maintain the suction yourself and controlled delivery of the head. So, right. So this one, inner term head, but not here. Thank you so much, Dr. Geeta, for bringing this. Thank you, Dr. Sangeeta. You were very accurate in answering all that. So we come over to the third case. We have 4 cases in total. So the third case is a 24-year-old unbooked patient who has been in labor for a day. She looks dehydrated with tachycardia, having contractions, but they are dying down quickly. FHS is still good enough. Head appears to be 3/5 palpable. On per vaginum examination, you can feel a rim around and the caput is down below. So definitely you know what you are dealing with, and one decides for C-section. Dr. Pavanpreet, do we have you here?
Yeah,
Are
yeah.
you back? Okay, so this is one entity. I know maybe your belt, you would be dealing with it. So looking at the case, are there any preparations or you would just like to take this patient and be on the abdomen, or you would like to give a minute and do some preps for her, anticipating some difficulties in delivering out the baby?
Ma'am, this seems to be obstructed labor or impending obstructed labor. So one has to be ready to deliver, deeply impacted head, deeply wedged head. And as we all know, it is quite difficult. Then all second steps are difficult, but when the went down, it makes the delivery even more difficult. So
any preparation you think you would do?
While taking up the patient on the table, we have to be ready so that, keeping in mind that one might need an assistant to push from the vagina. Though I am not very fond of doing that, but one has to keep assistant ready with the gloves on and 2 people to make the position so that, you have that frog leg position, semi-lithotomy, and then
so you
maybe
do it beforehand, just before planning the incision, then you have given that.
Ma'am, the incision, where the incision should be, you'd want to ask that?
I am saying, so you, before even starting the case, you first try to push from below. That's what you just mentioned?
No, ma'am. I'm just saying, while you're painting and draping, you keep the logistics ready so that you have an assistant free who can help you if you want. There are two people standing who can help you with the change of the position when it is required. And while catheterizing the patient, do it yourself, because it will be very, don't leave it to your assistant or to the nurses.
Brilliant, brilliant.
And while putting the catheter, once sometimes you need to push the head a little. So one should do it with their own hands. That is the best way to do it. And when
may I just reinforce what you just said, Dr. Pavanpreet? I'm so glad. See, catheterization is not just one thing that is procedure, because you yourself, when you are at the vaginal end, you would catheterize, you will do a PV and try to assess that is the head jammed or can you dislodge it a bit? Because that will help you
get
plan.
an idea there.
Whether you are going to getting it pushed from below or you plan something else if the head cannot be pushed. So I'm happy that my panelists are actually whatever was in my heart, everybody is speaking up. So nice. Yeah, carry on.
Placing the incision, I would like to say I would be a little liberal with the incision. I would not go for the cosmesis, a really, a big enough incision, because you will need some real manipulation to deliver the baby. And coming to the uterine incision, I would try to, really feel where the head is, where the anterior shoulder is, and accordingly, decide where to put the incision. And if you feel it's really struck, you might need to go for Patwardhan or some reverse breech extraction. It's better to go a little higher up. It's better to go up a little higher, and the incision should be curvilinear incision, and give a good incision on the uterus so that it doesn't extend and tear off the thing. We give a deliberately good enough incision, and the direction should be upwards, the C-shaped incision or inverted U, whatever you call it, so that if it extends, your uterines might be saved. And then first of all, I would once I've entered the uterus, I always like to try once to go laterally parallel to the back of the head, and if I can, try to flex it and pull it up. I do give it one try. I always find it better to try this than pushing from below. And if it is deeply impacted, you cannot do this, then you go on to the further steps, which are a little difficult. But with practice, everything can be done, and we all have done it. When you have to deliver the baby, you have to deliver it. First you flex and pull it out. If it doesn't come, ask somebody to push it from below. And the main point is to maintain the flexion. That really, really helps. First, you try to flex and give a jerk, dislodge the head and pull it out. Only then it will come. If it doesn't work, push from below. And the person from below also has to try and, try to flex the head and only then push it up. And if that doesn't work, then you try to see how the baby is positioned.
We will come over to the third scenario again.
Yeah, ma'am.
Yes. We'll come over to the shoulder part again, but you have rightly brought, Dr. Pavanpreet, I'm so happy. What she has rightly brought forth is that the safest method would be the head is impacted, jammed, you have seen and assessed from below. And if you're not able to move or disimpact, as Dr. Pavanpreet said, that you go along the baby's back, catch hold of the feet and try to pull down as reverse breech. It is, if you are trained, if you are competent at that, because that leads to least complications to the mother, endometritis, fetal complications, traumatic lacerations and other things. Only if you feel you are not comfortable with that, in that case, you have to get an assistant pushing from below. And in even that, somebody cannot be a novice because you cannot just poke your fingers. It has to be a hollow of your hand and not just the fingers which can go there, because you can enter the fetal head or through any of the sutures. So be very gentle once you are disimpacting from below. And if none of this helps, and then of course, I'm sure we would be able to bring out with pull method, if not the push method. So thank you, Dr. Pavanpreet. You were busy with the OT, but you
I
managed
finished it.
you
Finished
managed
it.
to you managed to chip in and absolutely crisp points. So any of people over here, if the uterine incision was a bit high up, as one tends to do, and you open it and the shoulder pops out, it's a day in and out situation. So then none of these methods really do help. Shoulder is already out of the incision. It is there.
Yes, Ruchira ma'am, Patwardhan method, that is the shoulder first method we can do. And first we will take out the anterior shoulder, deliver the anterior shoulder, followed by the posterior shoulder, then the trunk, then the bottoms, and then last is the head.
Head. Okay, good. That is the Patwardhan technique. I am sure youngsters are very fond of it, but even the seasoned ones, everybody has done that with thousands and thousands of cesareans. And this really comes to the rescue. There are no lacerations and extensions. And but once you are handling and catching hold of the baby, one has to take care at the thorax. That is, has to be an atraumatic delivery for the fetus. So this was just another modified Patwardhan. Dr. Patwardhan has brought out. People are fond of it, where none of the shoulder, only the shoulder, the back is posterior.
Occipito-posterior.
Occipito-posterior. So here you have this shoulder and this limb, then the other limb, and then the trunk. You can't have both the shoulders. Ek ka shoulder or usi side ka lower limb. Something like that is a modified Patwardhan, just for those who would be interested and those who have tried that down. There have been various indigenous methods to aid in disinfection and elevating the fetal head from below. And this is not something foreign. This has been used. This is a thin pillow. It is a thin, you can say a silicone pillow or a cup plate-like thing, which is slipped beneath the fetal head. Once you are assessing that if it can be slipped beneath, and then you inflate the saline. So as this bulb or balloon starts inflating to this much, it disimpacts or disengages and slightly elevates the fetal head. It is not theoretical. You will be surprised. This balloon, there have been n number of studies. There have been good RCTs and analysis. It is called a fetal pillow. Dr. Steele from Kolkata, he has had an RCT to his credit, where he found that this really worked. And because there is less blood loss, a good elevation, fetal conditions are also appropriate. There is least traumatic, and this works for as compared to the digital method of pushing from below. So, but yet again, it is not FDA approved, and meta-analysis has not recommended its routine use. It's available on the net, and I thought I'll just share with the panel and the audience. So fetal pillow is there, since there has been extensive research on this. So now we come to the
Ruchira ma'am, can we be quick with the last case?
Yeah, this is the last case, madam. So here we have an elderly primary gravida who is a bank officer, an educated lady who is booked case with Dr. Tanuja Bora. She has on her routine level 2 ultrasound got to know that she is carrying a 5 into 3 centimeter fibroid, and ever since her anxiety is just building up. And she says, madam, I don't want to take any chance, and please section me and deal with this fibroid in one go. So how do you counsel her, and what are, according to the appropriate candidates and indications for cesarean myomectomy?
Ma'am, for this patient, the two more things I would like to know: her hemoglobin, that is she a non-anemic patient? Yes. And the other thing, anterior, if the fibroid is in the anterior body, then is it in the upper segment or the lower segment? It's an
it is at the junction of upper and lower segment.
Upper and lower segment. Okay.
The hemoglobin
ma'am.
is medically and obstetrical low risk. It's just
Low
that
risk. Then I can plan an elective cesarean myomectomy for this patient after her consent and after explaining her about the risk also, like PPH, and in case of excessive bleeding, she may need blood transfusion, and sometimes, yes. Okay, sorry. So, ma'am, these are the pre-operative things I should plan for her. And on the table, when I will open her, I would like to see the position of the fibroid. If it is in the fundal region and near the tubes or near any vascular structure, then I would like to avoid it. Because, yeah. But if it is like serosal, pedunculated, easily
lower segment. It is there near the lower segment.
Near the lower segment, ma'am, I can remove it after delivering the baby so that I can easily close her. The closer becomes easier, and this will benefit the patient as it will avoid her second surgery. Maybe she can have some complications because of the fibroid in her puerperal postpartum time, or maybe for the subsequent pregnancy. We can avoid those complications. So I would like to go for a cesarean myomectomy for this patient after her consent and after explaining the risk and benefits.
What are the other fibroids you think are amenable to cesarean myomectomy? This one was an anterior body, any near the lower segment. Any other fibroids you would like to deal with during cesarean?
Subserous fibroids, they can be dealt with, pedunculated ones, and they are easily approachable. So we can deal with them.
And my point will be very different from this. Because I don't think like she's an ma'am, Ruchira ma'am.
Yeah, Dr. Jyoti.
I think I won't. I would counsel her for conservative management because she's primary gravid and the uterine size is only 5:3, and in gravid uterus it is like the fibroid also seems big. So I'm really sorry, but I won't counsel her for going for cesarean myomectomy. And because also I've seen in cesarean myomectomy, sometimes there is very torrential bleeding, even if the fibroid is small. So the fibroid behaves in a very unpredictable way. So I don't know what is the ideal answer for this, but somehow if I'm in a particular situation, I would rather counsel her.
Yes. You are right, because counseling is very important. That is what,
and the setup is very important. If you are in a tertiary setup and you are having the expertise, you can go for it. But if you are not in a tertiary setup and you are lacking something like surgeon support or something, then you can avoid it.
I just want to say that I am particular. If there's a spectrum, I am on the side of conservative management. I'm not on the side of cesarean myomectomy.
Let's ask Dr. Aarti.
Yes, I wanted to chip in because for this patient, I'll counsel her for a normal onset of labor, and I would like to do her cesarean just for an obstetric indication. And if I open her up for obstetric indication, of course, I would like to remove her fibroid. And if you give, dilute vasopressin after delivering the baby, the fibroids bigger than this also can be removed easily and is good hemostasis.
Yes, that is also correct.
Feel scared, and I don't think for a 5 centimeter fibroid anyone would refer the patient to a tertiary center. Any center who's doing cesareans, I think the doctor should allow her to deliver normal. And there are no postpartum complications as such for this myoma. They don't degenerate. We have had patients, with 8 to 10 centimeter size myomas who have delivered their both babies normal delivery, because after one normal delivery, they would come that, madam, it is such a big fibroid and we should remove it. But if you remove 1 8 centimeter fibroid in a lady who has delivered normal, next time she becomes a candidate for C-section. Rather, let her complete her career and then you can do a lap myomectomy. So
thank you, madam.
Younger generation, we should have a clear message.
Dr. Geeta, ma'am.
Yeah, I totally agree with Dr. Aarti. Yeah, this section should only be done for a obstetric indication and not otherwise. And then as she rightly pointed out, like we had a patient, like we usually have patient 8 to 10 centimeter, even 12 centimeter, they deliver vaginally. So you should counsel them ki yes, most of the time you will deliver vaginally. And in case if you land up in section, then yes, cesarean can be done. And another point which Richard I would like to make is you ask you what other indications, what other types of fibroids you would like to remove. So a fibroid which is coming in the, of course, that also have to be removed there and then.
You have to remove them.
These two things I just wanted to say.
Yes,
Yeah,
thank
I
you,
fully agree with Dr. Aarti. Yeah.
Dr. Pavan, yes.
Ma'am, I just wanted to add one thing, that what else you can remove not only depends on your expertise as an obstetrician, but also as how many other myomectomies are you usually doing? How adept are you to deal with such cases? And, what to expect. A person who is doing myomectomies routinely can deal with bigger fibroids also with ease, without much complications. And, you just don't need to push the patient for another surgery. Even if it's a big fibroid and you think you've closed the incision, then you can go for a myomectomy. If her cesarean part is over, she's not bleeding much. And, even if there is a large subserosal fibroid, you can go for it. I don't think you should defer it to the second sitting if you are confident doing myomectomies otherwise.
I
agree with this point very well.
Dr. Pavan, you have very rightly taken. As we see over here, other than the fancy anatomic location and everything, it is the expertise and experience. And
experience that comes.
Experience in doing skillful cesarean and experience in myomectomies as well. So
you would not start learning with the cesarean.
The literature is full of pros and cons. You have to decide what is the best for patient with adequate counseling, sitting down with the patient, allowing her till term and waiting for the spontaneous onset of labor. Of course, that is well accepted. So one cannot have a thought block or a rigid mind for any of these ideas. Surgical expertise and advantage of 2 surgeries, of course, should be offered.
It will save the patient from the cost of the second surgery, definitely.
Yes, of course.
So keeping in mind the holistic profile of the patient. So the key to successful myomectomies here would be after a detailed insight into the case, skilled surgeon, everything ready, build up hemoglobin, as you just said, fibroid which is coming in your way. In that case, pay attention to the baby first. Deliver the baby out through a safe incision and then deal with the myoma. The important point is you will put a cut on the myoma only when the uterus is contracted. Stay in the plane, use all the measures other than the pharmacotherapeutics. You can use surgical and mechanical measures also to bring the hemostasis, and of course meticulous suturing. We all know that. So I am so thankful to all the panelists and the experts and for bringing out the relevant, crisp carry-home message. So thank you all, Dr. Pavan, Dr. Tanuja, Dr. Archana,
Thank you, ma'am.
Dr. Geeta. And so in the end,
very well moderated panel, ma'am.
It was a wonderful session, ma'am.
अपने पास हर चीज का solution है, बस problem दूसरों की होनी चाहिए. So I end with this, and thank you team for having me here. Jaipuria ma'am and Sadhana Gupta madam, thank you so much, and my panelists.
Thank you,
Ruchira. Thank you,
Thank
Ruchira.
you,
That was
Dr.
wonderful.
Ruchira. Excellent panel.
Thank you, Ruchira.
Excellent.
Doctor. Thank you.
Very
and thank
interactive.
Thank you, Ruchira, for being us, and we are really very happy because your time was an issue. So somehow that cesarean section technique was coming on second line, but it was great to have you, and a wonderful panel. Wonderful. And I think but Nepal, Sri Lanka, Bangladesh, they are like overpowering. So wonderful similes you have done. So great. So
thank you, madam, so much. Thanks.
So now quickly we move on to the talk, and after hearing the amazing talk by Dr. Meenu Vash on indications of cesarean and Robson's criteria, and a great interactive panel discussion in different situations, difficult situations. The thank you experts, Dr. Geeta Jain and Dr. Aarti Luthra, for giving your wonderful tips and tricks and the final statements. So your points were too precious for us. So we are now eager to know the cesarean techniques which can prevent the complications and difficult situations. For this, I invite Dr. Sadhana Gupta ma'am for her talk. And before that, I invite the chairpersons, the learned, revered chairpersons we have for this session. Our chairpersons are Dr. Sangeeta Singhal. She is the head of the department, Bhel, Main Hospital, Hardoi, and she is the Haridwar, sorry. And she is the president, Haridwar Obs and Gynae Society. And she has a long 30 years experience in Obs and Gynae. Dr. Reena Ahuja is our second chairperson for this session. And she has been a gold medalist in her MBBS career, a decorated chairperson we have. She has achieved President Award for Best Student, publications in various national and international journals. She has participated in various national conferences as a faculty and has held many positions in Dehradun Obs and Gynae Society. She is especially interested in high-risk pregnancy and infertility. So over to chairpersons for further proceedings. Hello, Dr. Singhal, are you there?
Yes, ma'am. Yes, ma'am. Good evening, ma'am. Good evening. Good evening, ma'am. I would like to thank everybody, especially Dr. Sadhana ma'am, for bringing out this session and wonderful panel discussion and this lecture by Dr. Meenu Baish. And I would like to request Dr. Sadhana Gupta ma'am to please proceed for her lecture. And I would like to tell something about Dr. Sadhana ma'am. She doesn't need any introduction, but still she is the gold medalist in MBBS, MS gold medalist, and she is co-chair of the SAFOG NCT committee, FOGSI representatives of SAFOG, and she is a very strong candidate for this FOGSI presidential election as of now. She is governing ICOG governing council member, 3-time Korean Award winner, and 4-time best AICOG research paper. She has been the FOGSI part chairperson, FOGSI Safe Motherhood Committee with FOGSI Dr. Merudara Hansotia Award for the best committee. And she was a key organizer of national and international conferences, honored of National and International Forum for Exemplary Work done to reduce maternal mortality. And she is the awardee FOGSI Paper Achiever Award 2023. And she is a Pride of FOGSI Award, recipient of Dr. N.A. Shelza Pandit Award for Women Empowerment and Economic Times Award for Service in the COVID times. And she is Director and Senior Consultant of Obs and Gynae in Jeevan Jyoti Hospital and the Medical Research Center, Gorakhpur. And I welcome you, ma'am.
Thank you once again for coming for a generous introduction, and I'm going to share my screen for the cesarean section technique, which actually a lot of situation which Dr. Ruchira says, and I will just put your something attention to how we can, we are really troubled with the placenta accreta spectrum which is coming along. So the indications what Dr. Meenu says are rising, and more indications we are having for cesarean section, and it is a backlash for many scar complications. So I will merge two topics, that why there is a need for standardization of cesarean section technique, what are the things which are safe and which can prevent immediate and the future cesarean section complication. So it is about you on this auspicious International Yoga Day, which is something of the current century. We have made this day worldwide popular. I am really blessed to be with the people from the Devbhoomi. And this is a thanks for staying together. Like we have a wonderful association, and with Char Dham Yatra, and we are meeting Dr. Nautyal, everybody on a different cities in the different platforms, but it is a long association. So thank you for staying together. At the moment, my Karma Bhumi is land of Buddha, and he says we can never obtain peace in the outer world until we make peace with ourselves. Maybe it a difficult cesarean section situations. Maybe it is a the election, which is what we do for like serving the humankind at the wider platform. So it is all about peace and composure. Any difficult situation only we can keep when we are peaceful, we are composed, and we are having very good intention. So cesarean section, always a unique thing involving two life, only surgery which is giving birth to a something live. It is done for the physiological issue, most common abdominal major surgery. Around 30 million neonates are born all over the world by the cesarean section. Always the indication to everything management, it is in the backdrop of women empowerment. It is not a disease. It is not a something issue. It is a woman's choices, family choices, and the doctor's choices, and reproductive ancestral right. So cesarean section is something very, very different. We are having a backlash that why we are doing so much of cesarean section. Yet this is the time that WHO has reissued the statement that every woman should have the access to quality standard cesarean section, whosoever in need, and we should not go after any rates of cesarean section. And FOGSI says every woman can have the expectation, should have the successful and safe vaginal delivery, but must have the access to have the good cesarean delivery as well. So it is all about changing time, and we must be responsive to the need of changing time. So why we are bothered about the long-term scar complication and the rising rate of cesarean section? Because it is economic cost on the family, on the healthcare system, on the nations. Higher maternal morbidity and mortality, more perinatal morbidity we can have, and all the short and the long-term cesarean scar complication, especially the placenta accreta syndrome, which actually we are really troubled. What are the right diagnostic and the management modalities? And I will be talking that can we prevent these scar complication or not. So the first message right from the beginning, that it should always be a just cesarean section and not just a cesarean section. So these are the issues which we are dealing. These are all new papers which shows we can have a lot of post-cesarean complication, and surgical site infection is one of them. So these are the immediate scar complication, and we must have the risk assessment that whether women had any risk factor for the surgical site infection, like the PROM or the prolonged surgical time, anemia, or the obesities. We must be very, very particular about any sign of wound infection, because even a mild sepsis can lead to immediate as well as the long-term complication like poor wound healing. So it is not, it is always when we see it is a wound swab culture sensitivity, when it is a good antibiotic, and whenever it is needed, if it is sometime necrotizing, we have to do the surgical excision of the wound. So this is all what as a obstetrician and gynecologist and as a surgeon we know. Important thing is that two things which we can make to have a good wound healing. That is, the one thing is the proper aseptic precaution, not only in our cesarean section operation theater, but also in our labor room. And secondly, the prophylactic intravenous antibiotic. And it should be given, the timing is very important. That is 30 to 60 minutes before skin incision. So it is the right time is around when the anesthetist is going to have the regional anesthesia. It should not be 1 or 2 hours. 2 hours before, or it should not be after delivery of the baby. And you can use any second generation cephalosporin or MP-gentametrozole if it is available in your like a government supply or in your hospital. If there has been any high risk situation, the 5 days course for the antibiotic is fairly reasonable. So I will say, many times the Western world recommendation, it is only single and prophylactic antibiotic. But if there is any high risk situation for the infection, it is a quite reasonable what as an Indian OB-GYN we do, we give it for the 5 to 7 days. No, nothing universal safety precaution, good asepsis in our labor room and the cesarean section OT can replace anything for the surgical site infection. Now, the postpartum uterine dehiscence, like the postpartum hemorrhage is always contributing to 30 to 40% of maternal criticality and mortality. And postpartum uterine dehiscence can come to you not as a sepsis, but it comes to you, present to you as a recurrent postpartum hemorrhage as early as 10 days to 12 weeks after surgery. So just I want to draw your attention that so many times we share these patients with another, like some academic club, that patient is having recurrent postpartum hemorrhage and the ultrasound is okay and why she is having. So I am giving you few red flag signs for the uterine dehiscence. That is the presence of bladder flap hematoma, large pelvic hematoma, presence of gas within uterine defect. And if there are any such red flag sign, these situations need urgent surgical management. So the red flag sign I'm talking about, and it can lead to the cesarean scar defect and the cesarean scar pregnancy as well. So this is very, very important thing what we have to do. The second important thing which we are having in the modern obstetrics and gynecology, that is the pseudoaneurysm. And many people always, because we are having color Doppler, so the people are coming that it is a like a AV malformation or something. So AV malformation. So one thing I will say that any sort of sepsis as well as the suboptimal surgical technique predispose to the pseudoaneurysm. And we should consider in any case of the unexplained postpartum hemorrhage, pseudoaneurysm. And these are the pictures. It is not only the increased vascularity, which we term as the AV malformation. It is a typical yin and yang sign, which we see as a pseudoaneurysm. And always in these situations, when the patient is very unstable hemodynamically, many times you have to resort to hysterectomy. If the patient is stable, then we have the interventional radiologist like uterine artery embolization. So long-term scar complication can be all spectrum of the placenta accreta spectrum, and it starts from the scar niche and what is called the isthmocele or the scar niche or the scar defect. So I wish to draw your attention to this modality, which is not uncommon. Just we have to reorient ourselves to look into this. And you can see this irregular triangular hypoechoic shadow at the incision line, what we give into the lower uterine segment incision. Few etiology, a lot of things, deficiency of decidobacillus, this is the same thing, the constitutional endometrial defect. And important thing is the how we can prevent. It can be the right timing and the right technique for the cesarean section. So these are all new names for the isthmocele scar defect. What is ultrasound? Ultrasonologically, you can identify as a triangular hypoechoic or the anechoic shadow. The presence is as common as it around 24 to 70%, and the sonohysterography is an added method which can add to your diagnosis. More number of cesarean section, the woman have more chances that she have the scar defect. So the risk factor can be surgery related and the patient related. And this is the picture that if there is a normal scar, you will see just a small dot at the site of the incision. But if it is a scar niche, you can have the like a triangular irregular defect and the reduction into the residual myometrial thickness. So these are the few things which I wish that everybody look into a little bit with a lot of concentration, so that next time you do ultrasound, you are aware and you either confirm or exclude its presence. What else can be the risk factor? The adhesion formation, especially with the abdominal wall, which is pulling in the counter current force and affecting the wound healing, retroflex uterus, patient factors like the diabetes, obesity, Genetic contribution. So genetic predisposition, the today's science is always and always the two things, that is the genetics and the microbiome. And always a woman have a predisposition to certain complication. And important thing is the longer active labor prior to emergency cesarean section. So this timing is very, very important. And what we see, not only the technique, so what predisposes to the scar defect, that is either elective cesarean section. So many times patient is having repeat and we are planning around 37 weeks. So it should be close to the term, or we do the cesarean section in advanced labor. So second stage labor, the late stage labor cesarean sections are always complicated, but the very early elective cesarean section without onset of labor or around 37 weeks can also give you, because you are not putting the incision at the right place, what the lower because of the underdeveloped lower uterine segment. So these are the few things that it is not only the technique, but it is your asepsis, your antibiotic prophylaxis, and your timing of cesarean section also add to the presence of the placenta accreta and the scar defect syndrome. Places of cesarean section, it is something what we say in our like a routine conversation, that no, my cesarean never landed into the next placenta accreta. It is the cesarean done elsewhere. Actually, the China paper one says that if the cesarean section is done in a rural or the peripheral hospital, actually what does it mean? Where we don't have that quality obstetrical facilities, be it in sterilization, be it in a expertise, where we can have more number of cesarean section. Beside this, higher the maternal age, more number of cesarean section, more number of induced abortion. And I'm really thinking about that the patient, even if taking a number of times medical abortion drugs, which is a so common scenario in today's practice, can add to these complications or not. So what are the modifiable factor and what are the non-modifiable? Non-modifiable thing we cannot change in our world. So if there is any difficulty in life, we have to. So it is a age, it is retroverted uterus, we cannot change. We can change a little bit labor related and surgical technique. What we can do in the surgical technique, that is a good technique. Incision close to internal, or exclusion of endometrium during repair, and single layer closure. These are the things which has been related to the more chances of a scar defect and the placenta accreta spectrum. It can present to you. I will just go a little bit into gynecology. In gynecological clinic, it can be asymptomatic. It can come to you as a abnormal uterine bleeding, like a post-menstrual spotting, continuous bleeding, prolonged bleeding, lower abdominal pain. So in previous cesarean section, today we are so much obsessed with endometriosis, any chronic pelvic pain which does not respond to simple analgesic antibiotic, we put onto the like a Gynaecologist or something. I will say, beside adhesion, the scar defect can also present as a chronic pelvic pain, and we must be careful about its diagnosis on ultrasound examination. And we can have a mid-cycle intrauterine fluid accumulation. Also, it can present on the ultrasound finding. Secondary infertility is very, very important presentation of these scarnic. And if we are doing IVF, we are not able to have a easy embryo transfer, and we are having more and more higher IVF failure. Bladder dysfunction and scar abscess can also present. So this is the thing that obstetrics, what we say, gynecology is the legacy of obstetrics. That is a golden dictum. And the all presentation says to you, it was the section which was done in some way in a suboptimal, right from the timing to the antibiotic prophylaxis to the technique, and the patient have the gynecological problem as well as the secondary infertility. So these are the beautiful paper from our own country as well as from abroad, that it is a very much reality, and it is a beautiful paper by Dr. Indranil Datta, that what we are facing, we are not diagnosing scar niche or having something. We are facing the patient took medical abortion, or she took you are doing surgical evacuation, and we are suddenly having the life-threatening hemorrhage. So this is the reality which all these papers says, and that's actually emphasize that we must be aware of this entity. And what is this is the picture, it is a hypoechoic shadow, and what makes the prognostic issue, that is the residual myometrial thickness. So these are the ultrasound picture. It can go outward, it can go inward, and you can have concavity, sometime abnormal vascularity, sometime not also, polyp-like structure. And what we say, TVS added on the sonohistography gives you good diagnosis, and you see it is a catheter in the uterine cavity, and you see the fluid going into the isthmosis. So indications, not every scar niche you feel you see does not require treatment. It is chronic pelvic pain, abnormal uterine bleeding, or secondary infertility. When we need treatment for AUB, COC may be a good choice. LNG IUD not found to be effective. But if the patient is having secondary infertility, it is a big niche, she is having a resistant abnormal uterine bleeding, then we have to go for the surgical route. That is a resection by hysteroscopy, excision plus repair, either by transabdominal or laparoscopy. And Dr. Alka Kriplani have got a beautiful selection of the cases she shows in the video, which she is having off and on for the niche, like a very, very high, the big size of the uterine niche. So this is all which I want to draw your attention, that is entity. And the secondary prevention is by the good surgical technique. So right timing, what we say, cesarean section at onset of the labor is the right time, because you have a good distended lower uterine segment. You put the incision at the right place, neither towards the upper uterine segment nor towards the cervix. So it gives you the good healing. So this is very, very important. And the pre-labor cesarean section is result into the more number of the scar niche. So this I want to emphasize again and again. And this is the where when screening pregnancy for abnormal placental invasion, knowing intrapartum timing of previous cesarean section is of critical importance. Now, when we do the cesarean section in discharge slip, we sometimes really forget to write even the bicornate uterus, presence of anything extra. So this is important that we have to mention in our discharge card that it was an emergency cesarean or it was elective cesarean, and if done, it was on the 37 or the 38 week. So Atul Gwande is the person which we have exchanged our book at the Brazil last FIGO in the Brazil. And I think I will say everybody, every youngster and every senior person, do read the non-medical fiction which is authored by the doctors, because it gives into the deep psychology of a surgeon, deep psychology of the patient, and we understand the medicine on a deeper way. It is not only the like fixing some solution. It is medicine is something much beyond it. It is much more about the care, and they emphasize that there is a need for the standardization of the cesarean section technique. Why? Because in every institution, in every unit, we are having different technique. Everybody says that my technique is good. We are having a lot of research paper which is actually confusing the more, and there has been the worldwide recognition of this need that we must have the standardization of cesarean section technique, so that we have a good interpretation of research paper. We have a good training for the OB-GYN resident, because most of the institution, it is a third year teaching second year and second year teaching first year, and we don't know actually what is going on. So a little bit, what is the conventional, what is the neurosurgical technique? So these are the conventional technique, what we say, what the Ruchira and the all panel have done. It is right, the images from my own books. So I will say few things which the standardization actually recommend, that is the Joel Cohen incision 2-3 centimeter. It is not fan steel, which usually the people recommend for the standardized technique, because it is a fast, it is a easy, no sharp dissection. Bladder flap development is a question mark, though there are again two view. Usually we want to have the bladder flap development, and the uterine incision, that is a 2-3 centimeter transverse uterine incision, blunt entry, and the cephalad colon extension. No placenta removal by the manually, no intrauterine wiping, no routine cervical dilatation. Uterine excision is a preferred thing. because the advantage are many. You can see the tonicity of the uterus, you can feel the adnexa, you can visualize posterior aspect of the uterus, that there is nothing, any hematoma or something, and you can rule out the adnexal pathology. And whenever you want to have any additional procedure like selective devascularization, the uterine acceleration is recommended. So I want to emphasize, the most important part is the double layer closure, and that should be the non-locking. I will just go into a little detail. Omit intra-abdominal irrigation, omit visceral peritoneum closure, omit rectus muscle approximation, omit routine glove change, and the rectus sheath continuous closure with delayed absorbable suture, subcutaneous tissue suture only when there is more than 2 centimeter depth, and skin either by the staple or the subcuticular absorbable. So this is what I say. Most of the studies say that the acceleration is good enough. So at least we must have been used to do the in situ repair, as well as we should not take any egos about it that we extrudize the uterus, because the study says that it is better. 2-layer non-locking suture is the thing which all studies recommend, because I know even today in our audience, few people were very, very fond of doing the single layer non-locking suture, but the 2-layer suturing gives inclusion of the decidua, gives the better scar, what all studies says. So all high quality evidence shows that the double layer closure result into the higher residual myometrial thickness compared with the single layer closure. And when we do the single layer closure, more chances of isthmocele as well as all the complications related to placenta accreta spectrum. So these are all new studies. I just wish to believe that you believe into the double layer suture and the non-locking, beside all surgical principle of the surgery, that is a good hemostasis, no extra excessive tissue manipulation just for your insecurity, seeing that tissue, seeing again and again, devascularization, very tight locking suture, very close suture. So these are the simple principle of surgery. Just we have to be very careful that we are doing in right way, and more important that we are teaching our young OB-GYN and the residents right way. So few alternative methods have been proposed to have a strong myometrial thickness. So this is a modification of Misclave technique, which shows that you can have the don't go by the any centimeter like Joel Cohen or Fan Steel. You just follow the natural skin, uterine skin crease of the woman, and you just follow the baby's head for the size of the incision, and the closure of uterus is done using 2 continuous suture, which are then knotted together, which result into the short double layer closure. So these are the few pictures, the things which have been proposed. They are not the standardized, but I'm just taking that you take away, because we are having the people from the teaching institution. And this is the double loop suture that goes from the caudal to syphilis. So it is a 2 loop. So it takes in a one go, it takes the 2-layer closure. And when you pull, you have a pull that both the loops are getting strengthened. And the author says that it gives you the better approximation of the uterine wound and a good wound scan. So finally, as a surgeon, we believe in practice, not talent. So we are curious, we are a labor man. We learn and we go on improving. So finally, cesarean scar defect is a new entity. We must be aware of all these things. The primary prevention by reducing cesarean section rate, secondary prevention by a very good surgical technique, as well as the timing of cesarean section. And it is a good practice that we can be more aware that after 12 weeks, we call the patient back, so we can utilize the opportunity for contraception, for how the baby is going, about the weight loss, and we can also see for the scar defect in our routine ultrasound. And yet we have to have a real standard diagnostic and management issue of the cesarean scar defect. So finally, they say the world has become too complex for simple answers. Actually, they are wrong. So the FOGSI leadership also need this time. Now, the very simple and the person with commitment and conviction. And I can say that in my all journey of the FOGSI, I have taken this philosophy in the principle, in the action. So I appeal everyone, thank you everyone, every mentor, teacher, leaders, seniors for the Uttarakhand Society for your full-hearted support for a great association. And I appeal that every vote from the Uttarakhand should go for me, because together we can make a lot of change. Thank you very much for the patient listening, and thank you very much for every.
Good evening, everyone. Can you hear me? Hello?
Yes, Doctor.
Dr. Reena, go ahead. Good evening, everyone. Yeah, can I speak, ma'am?
Go ahead.
Good evening.
Yes, ma'am.
Good evening, everyone. Dr. Sadhana Gupta has indeed proved once again her academic excellence. She is indeed the teacher of teachers. If we were today in a physical meeting, she needed a standing ovation for this kind of lecture. Absolutely marvelous, ma'am. Hats off to you. She has so beautifully described the scar niche and isthmocele, which is the topic which we have not grown up with. And it is so important. The reason why it is there, when a patient comes to you with post-menstrual spotting, that is one of the DD. How to prevent an isthmocele, what is the right time to do elective cesarean. She has all these key points. She has made us so beautifully, she has described and made us aware. The other thing she has described is that single layer closure is an absolute no for prevention of isthmocele. Locking of sutures is an absolute no for prevention of isthmocele. These are key points. Then she has beautifully described the Misgav ladder technique, the importance of all the basic points, the jewel cone incision, exteriorizing the uterus, the single layer closure, no mops needed, so no bladder dissection. So all these newer techniques and new points are very important for us today. These are the key points. So hats off to you, madam. That is a very good discussion and excellent lecture. Thank you, ma'am.
Thank you, Dr. Reena, for your brilliant comment. Thank you.
Thank you, chairpersons, Dr. Sangeeta Singhal and Dr. Reena Ahuja. And thank you, Sadha ma'am, for a great talk. So we quickly move on to the last talk of today, and that is on post-cesarean care and complications, and will be taken up by Dr. Anjali Chaudhary. And for this, I would love to call upon the chairpersons. Our chairpersons are Dr. Rekha Srivastava. Dr. Rekha Srivastava is an alumnus of LLRM Medical College, Meerut. May I have the slides, please? She is working at Savitri Nursing Home and Research Center. Yes, Savitri Nursing Home and Research Center as a senior consultant for 35 years. And her special field of interest are high-risk obstetrics, infertility, endoscopy, cosmetology, and laser therapy. She has achieved many awards, and especially the Doon Diva Nari Shakti Award, Uttaranchal Mahila Association Award, Lions Club Appreciation Award. She has many publications to her credit, and she is an invited faculty to all the major conferences. And our second chairperson is Dr. Archana Singh. Dr. Archana Singh is the Secretary, Uttarakhand Chapter. May I have the CV, please? She is the Master Trainer of Respectful Abortion Care. Yes. Dr. Archana Singh is the Director, Siddhi Vinayak Hospital, Haldwani. And she is also the Secretary, Uttarakhand Chapter of Obs and Gynae. And she has conducted and organized many webinars, CMEs, and conferences. And she has held many positions in Haldwani and is the Master Trainer of Respectful Abortion Care Training Program by WHO and FOGSI. So over to chairpersons for further proceedings. Rekha ma'am.
Good evening, everybody, please. Can you listen me?
Yes, ma'am.
Okay.
We can hear you.
Yes, yeah. First of all, I would like to thank Uttarakhand Society of Gynae and Obs for inviting me to chair this important session of day-to-day practice. Cesarean, as we know, is the most common surgery which we obstetricians are doing. And at one hand, it is taken as an easy surgery. On the other hand, it requires a lot of care. And after discussion of all the aspects of cesarean, now the next thing is how to do the care of cesarean patient after delivery, after cesarean and its complications. Now, the speaker for today's session is Dr. Anjali Chaudhary, who is a great academician, and she is a professor and in Department of Obs and Gynae at SGRR Medical College, Patel Nagar, Dehradun. She is graduate and postgraduate from Nagpur University. She has 33 years of post-PG experience, technical in charge, skill lab and coordinator, medical education unit of SGRR Medical College. She is life member of FOGSI, ISAR, Endometriosis Society of India. She has research publications in national and international journals. I am eager to hear from Dr. Anjali Chaudhary, and I would invite her to speak on the topic of post-cesarean care and complications. Dr. Anjali Chaudhary, please start your session.
Thank you, Dr. Rekha, for that kind invitation. And the introduction was excellent, and I don't deserve that. But I would like to, at the outset, thank the organizers of this workshop for organizing this excellent workshop on cesarean section, because cesarean section, as we know, is a very common surgery that we do every day. And we have done it so far, many hundreds of thousands of cesareans we may have done, but still the technique is not perfect. Still there are some lacunae in understanding that leave places for complications. So I was invited to talk about the complications and aftercare of the cesarean section. And I would like to, at the outset, thank the organizers of this workshop for the excellent idea to talk about cesarean section, a much needed, relevant topic, but much neglected topic also, because on one hand, we talk about very high-end robotics and laparoscopic surgeries and forget the routine surgery that we are doing that needs a great attention and discussion. Thank you, Sadhana Gupta ma'am, for your excellent oration. It was really eye-opening, and there were so many new pearls of wisdom that you brought out. And thank you for your journey towards your presidency. And I hope you will be successful. And we are all with you from the Uttarakhand. We are all supporting you. Dr. Minuvesh, Uttarakhand Society is running because of you, because you are so great and are the pioneer of the societies, all CMEs. And she's such an excellent person. Yeah. And thank you, Dr. Thank you, Dr. Minuvesh, for being there. Her smile itself is so invigorating that, you think the CME is not a CME.
You are not Dr. Chaudhary?
Yeah, no, I'm not audible, ma'am. Am I audible?
Yes, I can hear you.
Yes,
we can hear you.
Now you are audible.
Thank you so much, ma'am. And I would like to thank our chairperson, and organizers, Dr. Amrita, Dr. Ritu, for inviting me for this discussion. And I'm really grateful that I don't know, most of the things have been already said by Dr. Rachira Notial for excellent during her excellent panel discussion. Many points that I was supposed to talk, Dr. Sadhana Gupta has already covered. So that makes my job a little bit easier. So I have to talk less about it. So thank you so much for inviting me. I would like to share my screen now. Is my screen visible, ma'am?
No, ma'am. No.
No.
How do I do it?
Yes.
Is it visible now, ma'am?
Yes.
Yeah, it is visible.
Oh, it is visible.
Kindly put in the screen share, slideshow.
Slideshow. Okay.
Slideshow. The wine glass you need to click.
Yes.
Yes.
Is it okay now?
Yeah, wonderful. Yes, it's done.
Thank you for being patient. And I'm supposed to talk about cesarean section and complications and aftercare. So here it goes. So I'll be talking in that context of background of the cesarean section, increasing section rate. Is it a cause for concern? I will be talking about the complication, intraoperative, immediate post-op and late complications, consequences for the next pregnancy, and the post-operative care from the recovery room, post-op care, discharge plan and post-discharge, And then at the end, we would like to summarize the whole discussion. So cesarean section is the commonest surgery done worldwide. We all know that universal access to cesarean section is a key requisite to improve maternal and perinatal outcome and is an integral part of the WHO comprehensive obstetric care. And the proportion of the deliveries done by cesarean section in a geographical area is a measure of access to and the use of a common obstetric intervention to avoid maternal and neonatal complications and for preventing complications such as fistulae. This is from the WHO, so I wanted to be verbatim bit right because this is from the WHO EOC care. But in the recent times, we have all seen that there's an exponential rise in the incidence of cesarean section deliveries, and so are the complications are also on the rise. The procedure has many inherent complications, needs a lot of aftercare, and has immediate term and complications and consequences. So cesarean section is to put it as a definition in a context, the cesarean section is an abdominal delivery of a viable fetus after a laparotomy and hysterectomy when the vaginal delivery is either not possible or is deemed to be detrimental for the maternal or fetal life. There is always a mystery behind the name cesarean. Sometimes it is said that it is because of the Julius Caesar, the Roman emperor. We don't know that because Julius Caesar was definitely not born out of the cesarean section. Lex caesarea was a rule in the Roman Empire to cut open the abdomen of a dead mother to deliver the baby and have the baby a separate grave. Cedar refers to a Latin word for cut. So maybe it is come from there. We don't know where the name originated. And the cesarean sections were originally done to save the fetus from a mother who's dying or already dead. The first cesarean was documented in 1020 AD, and since then it has evolved a lot. There is a rising section rate nowadays, which is a cause of concern. WHO in 1980 stated that the cesarean section to be limited to 15%. Anything more than that is unnecessary and will add to the maternal morbidity and mortality, but the rates have changed drastically since then. Worldwide section rates have risen from 7% in 1990 to almost 29% today and continue to increase in this current decade. Nearly a third of the births are likely to take place with cesarean section. And the projections show that by 2030, 28.5% worldwide will have given birth by cesarean section. That is whooping 38 million cesareans, out of which 33.5 million will be in the low middle income countries annually. About 7.5 in the sub-Saharan Africa and 63.4% in Eastern Asia. This is the projection for the year 2030. So this is a world map of cesarean sections and their frequencies, how it is distributed worldwide, but this is not a very fresh data. This is maybe 17 or 18 data. So increasing section rates because of these are the complications, but increasing maternal age, electronic fetal monitoring, which can be a ban or a boon for the labor monitoring. More fetuses in breech, maybe not, but absolute safety is needed for the breech deliveries. So more cesareans are performed for the breech so that we're losing the skill of delivering a breech vaginally. Rising indications for incidences of labor induction. And labor induction, as we know, is fraught with complications and needs cesarean for the failure of induction and fetal distress. There's a decreased frequency of the forceps and venous delivery, which is we are losing the skill of delivering the women by forceps and mid-cavity forceps. Definitely has gone out of the fashion. Increased prevalence of obesity. And obesity, as you know, is an independent factor for the difficult delivery and needs cesarean section. Section for preeclampsia per se not an indication for section, but something goes wrong and we need to do a section. VBAC deliveries are reduced and cesarean for social reasons and maternal requests are increasing, and opting for a safer mode of delivery to avoid malpractice litigation is an important area that we had not dealt with in earlier times, but it is rising slowly. So amongst those indications, the four indications come out as clear as a 4: fetal jeopardy, malpresentation, previous section, and non-progressive labor, and these make up about 85% of all sections. So irrespective of the indications, the procedure has its inherent complications and risks. The complications rise with each repeat sections, but not all cesareans are carried out for the moment are needed for medical reasons. Unnecessary surgical procedures can be harmful for the woman and her baby. The rising section rates are medically unnecessary or potentially harmful procedures. This is from a WHO leaflet of 2022. So what are these complications they're talking about and which women are prone to have these complications? The obstetric condition, when you are doing an emergency cesarean section or a prolonged obstetric labor, a previous cesarean section, placenta accreta syndrome is a king of all complications. You think about any complication that can happen in a cesarean section, and it will happen in a placenta accreta. Multiple pregnancy, placental abruption, antepartum hemorrhage, chorioamnionitis, and many maternal medical conditions will add to the complications. Complications increase again with the increase in number of cesarean sections. So I will discuss maternal complication in the intra-op complication, post-op complication, late complications, and the next pregnancy complication, balanced against reduced incidence of perineal injuries, vaginal lacerations, lower pelvic floor injuries, and lesser rate of obstetric fistula and obstructed labor. This is what happens in a vaginal delivery. And for the neonate, lesser birth trauma, lower rates of fetal deaths, but an increased risk of fetal respiratory morbidity in a cesarean section. So maternal mortality in a cesarean section is on the rise. Higher maternal mortality for the current pregnancy as well as for the subsequent pregnancy is noted. Clark and R, in a review of more than 1.5 million cases, report of maternal mortality of 2.2 per 100,000 live births in the cesarean delivery as opposed to the 0.2 per 100,000 births. And another study says 13 maternal deaths per 100,000 births versus 4 per 100,000 births in live women undergoing VBAC. So VBAC is definitely a better option for the cesarean patient who had a previous one cesarean section. And Velour and all observed that the increase in the morbidity and mortality in the cesarean section is because of subsequent to infection, hemorrhage, and thromboembolism. Adjacent organ injury is again one more complication. The bladder injuries account for 1 to 3,000, ureteral injuries 0.3 per 1,000 deliveries, and bowel injury per 1 per 1,000 deliveries will be there. Complications cesarean section, usually this is a routine list that we are all familiar with. I'm just going through it. We all know these complications. Intraoperatively, we can encounter hemorrhage, PPH, because of uterine atony, trauma, bleeding from the incision site or extension of the incision, lacerations to the upper or lower uterine segment, broad ligament hematoma, bleeding from the placental bed, especially when the patient is having a placenta previa, a central placenta previa where the lower uterine segment fails to contract completely. You can have placental side bleedings. Injury to the surrounding organs, bladder is very close by. Injury to the gut, rarely the ureter also may be encountered in injury, especially when you are looking for the extension of the lower uterine segment incision and trying to clamp the uterine artery at the angle. That is where the ureter is most likely to get injured. Anesthesia complications like the hypotension, shock, high spinal leading to respiratory arrest and mechanical ventilation and need for intubation, aspiration, convergence, and hypertension are again complications of a general anesthesia. Convulsions can happen because of an accidental entry of the anesthetic agent into blood vessel during a spinal anesthesia. Surgery-related immediate postpartum complications can be febrile morbidity. Secondary PPH are the bleeding that occurs after 48 hours. Mostly is because of the endometritis and the infection. Urinary retention about 0.7%. Urinary tract infection, catheter-associated UTIs, wound infection, gaping, DVT, thromboembolism, puerperal sepsis, lactation issues, and later anesthesia-related complications like the spinal headache, typically on the third day, meningism, and rarely meningitis. So the delayed complications can be incisional hernia, intestinal obstruction, chronic pelvic pain, chronic backache, and delayed difficult subsequent surgery due to adhesions. Complications for the next pregnancy would be cesarean scar pregnancy, heavy bleeding during the menses, placenta accreta syndrome, difficult deliveries next time, scar adhesions during the labor, and repeat cesarean section. So hemorrhage, if you look at the hemorrhage during cesarean section, this has all been talked about. The risk factors, as you know, are the second stage section, obstructed labor, previous LACS, and placenta accreta syndrome. Prevention strategies should begin in the antenatal period. Anemia correction as a part of antenatal monitoring, use of oxytocin at the right time during cesarean section, and recent RCT shows the use of carbetocin, ergometrin, and tranexamic acid 1 gram IV before the surgery is beneficial to prevent PPH, especially in the high-risk woman who is has a high risk for having PPH. It can be beneficial. Ergometrin is a very good drug which is stable at the room temperature. and has been on a holiday for a long time, it contracts the upper and the lower uterine segment contonically and achieves beautiful hemostasis, which oxytocin may not be able to do so much. Complications like the post-operative complications, sepsis. Sepsis after cesarean section ranges from 3 to 15%. Also is associated with the maternal mortality of 3%. If not diagnosed early, cesarean sepsis can lead to septic shock. The risk factors, as a common knowledge, PROM, prolonged or obstructed labor, postpartum hemorrhage, systemic infection, poor postoperative care, anemia, wound contamination, poor antibiotic selection and immunity. Major pathogenic organisms can be everything under the umbrella of the microbiology that you can have. Staphylococcus, Proteus, Pseudomonas, Klebsiella, and Enterobacter. Clinical features can be febrile morbidity, vaginal discharge, wound infection, pus discharge, raise neutrophil counts, raise CRP and procalcitonin, positive cultures, urine culture, pus culture, blood culture. Treatment, of course, involves appropriate antibiotic as per dictated by the cultures and supportive treatment. Deep vein thrombosis, again, is a very rare combination, but life-threatening combination, and is associated with the pregnancy. In a 5 to 10-fold increase of venous thrombosis is there in the pregnancy. And the absolute risk is highest during the delivery and immediately after cesarean delivery. The risk of venous thromboembolism is 4-fold greater in cesarean section than following a vaginal delivery. The risk for thromboembolism is maternal obesity, previous history of venous thromboembolism, a genetic predisposition or a family history, varicose vein, heart disease, thrombophilia, either acquired or inherited thrombophilia, immobilization such as bed rest or long distance travel, and twin pregnancy. Prevention is a key to prevent thromboembolism. Recommendation by the Society of Maternal Fetal Medicine suggests compression devices starting before the surgery, post-op, until post-op till ambulatory. Grade 1C recommendation. Women with a history of VT and thromboembolism should receive compression as well as pharmacological prophylaxis. Grade 2C recommendation with women with a history of previous thrombophilia should receive compression devices and LMWH till about 6 weeks postpartum. And pregnant women with class 3 obesity should receive LMWH perioperatively. Especially it should start in the postoperative period, about 6 to 12 hours is recommended time to avoid the danger of the bleeding during the surgery. So deep vein thrombosis, although operative delivery further increases the risk of VTE, there is still no consensus on thromboprophylaxis after the elective cesarean section. So what do you do? So there was a study in the thromboprophylaxis by Joyce Lyon et al. And the two groups after cesarean delivery, they had 1,377 patients, out of which 137 received heparin and 1,233 did not receive heparin. Out of 1,233, the women that did not receive heparin, 7 developed VTE, 0.5%, out of which 86% had developed thromboembolism, and 23% those women were hypertensive. So hypertensive women around the cesarean section are even more prone to develop thromboembolism. A meta-analysis of the cesarean section on the venous thromboembolism found on an average 3 in 1,000 women will develop VTE during a cesarean section and should be recommended a thromboprophylaxis. Wound complication, already Dr. Sadhana has described to some extent surgical site infection, but just to cover the basics, it varies from 3 to 15% and associated again with the maternal mortality and morbidity, ranging from up to 3%. SSI may increase morbidity, longer hospital stay, and increase cost of care also at the same time. Wound complications are again more prevalent in women with the PROM, chorioamnionitis, prolonged or obstructed labor, long duration surgery, maternal obesity, diabetes, anemia, poor hygiene, and poor immunity. Prevention is a key to prevent wound complication and wound infection also. So management of the comorbidities should start from the antenatal period. During the preparation for the cesarean section, hair clipping is advised rather than shaving. Skin preparation with iodine, chlorhexidine, or alcohol is recommended. Vaginal preparation with cleansing of iodine before surgery prevents a lot of postpartum complications like the wound infections. Antibiotic prophylaxis at the right time with the right antibiotic is a great help in preventing infections. During the cesarean section procedure, Joel co-incision is less prone to develop wound complications. Spontaneous removal of the placenta should be waited instead of manual removal of placenta. Exteriorization versus intra-abdominal layer has no effect on the infection rate in the surgical site infection. Uterine closure, single layer or dual layer, has no difference on the SSI. Peritoneal closure or non-closure, again, has no difference in the incidence of SSI. Subcutaneous tissue closure or drain, keeping a drain, especially for a morbidly obese woman, does not alter the infection rate. Skin closure with staple and interrupted has a higher infection rate as compared to the wound closed with subcutaneous sutures. So this is where we go. Wound complication can range from hematoma, seroma, induration, discharge, or pus discharge from the infection, seropurulent or purulent, infection, gaping, and the need for resuturing. CDC defines SSI as an infection occurring within 30 days of surgery. So this infection could be a surface infection to the skin, limited to the skin, deeper to the rectus sheath and below, or organ space infection, which includes pelvic space infections. And factors causing SSI could be host related, procedure related, and environmental contamination related. Pre-op assessment, post-op assessment should be daily inspection of the wound for erythema, induration, purulent discharge. Follow up the wound after the discharge from the hospital also. Management should include antibiotic treatment, wound debridement, exploration, and signs for pelvic infection. Broad spectrum antibiotics should be initiated, including anaerobic coverage. Necrotizing fasciitis is a rare but serious complication causing gangrene and the loss of skin. So Dr. Sadhana had a beautiful picture of necrotizing fasciitis, and it can be a nightmare to close that wound. So late complication can be, this has already been discussed in Dr. Sadhana's talk, but just to touch surface of it, a scar defect associated with the premenstrual spotting, dysmenorrhea, a cesarean scar pregnancy, scar endometriosis, pelvic adhesions for a chronic pelvic pain decrease, fertility rate, a secondary infertility patient might come to. So we may come across many women in the OPDs with one cesarean section successfully done, and second time she has difficulty in conceiving. So it could be adhesion related, could be the morbidity of the cesarean related, or there could be a subclinical infection around the uterus and the adnexa following the last cesarean section, which has caused little bit of peritonitis and tubal infection and adhesion, which is causing infertility. A 2021 Swedish study spanning over 11 years in 79,000 women who had sections observed an increased risk of late surgical complications like bowel obstruction, chronic abdominal pain, incisional hernia, and all other surgical complications. And among these 79,000, they observed bowel obstruction in 436 women, incisional hernia in 727 women, abdominal chronic pain 16,951 women, organ damage in 257 women, bowel obstruction in 663 women, and so on and so forth. So there is a lot of, the cesarean is done and done for, and the baby is there, mother is there, but we should not forget that a lot of long-term complication that the patient might suffer for a long time because of this pain. Subsequent pregnancy complication is scar pregnancy, which is a nightmare and a challenge to treat. Placenta previa, difficult neck cesarean section, uterine rupture in the labor, and placenta accreta syndrome. The risk of placenta accreta is 3%, 11%, 40%, 61%, 67% for the first, second, third, fourth, fifth, and more repeat cesarean deliveries. So if you see a scar pregnancy in the first trimester, diagnose it with the ultrasound and give methotrexate systemic or local intrasac methotrexate, kill that pregnancy at that point so that it does not progress to the placenta accreta syndrome and you have a nightmare on an operating table. Fetal complication, of course, we should not forget. The risk of fetal trauma is about 1%, skin laceration, fracture of the clavicle or the skull, facial or brachial plexus nerve damage, especially during the delivery, difficult delivery of a woman who has oligohydramnios or drained liquor, Kefal hematoma, which has already there because of prolonged or obstructed labor. Respiratory complications, they have babies born by the cesarean section have higher rate of allergy and asthma. They have transient tachypnea of newborn. 4.2% have repeat in the repeat cesarean sections, and need for bag and marks about 2.5%. So neonates born after repeat cesarean section, there's a respiratory morbidity and higher incidence of NICU admission and morbidity. So in the meta-analysis, about 1,600,000 women, about 3,027,000 neonates observed that respiratory morbidity in cesarean delivery was about 95% as opposed to the vaginal deliveries. So cesarean section itself proposes a great risk of the fetal respiratory morbidity. According to Jordanian study, babies born to the cesarean section had a higher rate of NICU admissions, about 30%, or mostly for the prematurity, low Akbar source, RDS, and transient tachypnea of newborn. Okay, this is done. So fetal complications can be low birth weight, stillbirth, neonatal deaths, and low Akbar source. Again, all of which is going to need neonatal admissions. Elective sections, strategies to reduce fetal complications is elective sections should be planned at 39 completed weeks of pregnancy and not a day before, unless they are medically indicated. Preoperative corticosteroids for sections less than 39 weeks. Sharp nick followed by blunt opening of the incision. Delayed cord clamping and careful handling of the baby can reduce a lot of fetal complications. So that about done complications cesarean section. We are coming to the cesarean section and aftercare. What do you do once you done a cesarean section? The baby is out, the mother is fine. You have to put the patient in the recovery room. What to do after that? So Society of the recommendation for enhanced recovery after cesarean section recommends limit fasting. This is pre-op. Your care for the post-op care should start in the pre-op period. Limit fasting time before surgery. Solids 8 hours prior and fluids 2 hours prior. Non-particulate carbohydrate drinks for the non-diabetic mothers can be given up to 2 hours before LSCS to prevent post-operative hypoglycemia. These are the new recommendations because we say about 5 to 6 hours of nil by mouth patient should be for a safer anesthesia and post-operative recovery. Prophylactic vasopressors to reduce spinal anesthesia-induced hypertension. Maintain normothermia during cesarean sections. Optimal uterotonic administration to reduce post-operative blood loss. You can even give carbetocin and tranexamic acid 1 hour before or even before the incision is given. Antibiotic prophylaxis should be according to the ACOG guidelines. Multimodal anesthesia, neuroaxin, long-acting opioid with morphine, ketorolac, and acetaminophen IV before and after the delivery as an analgesic. Delayed umbilical cord control at least 30 to 60 seconds and start early breastfeeding for the safer in the earlier initiation of the lactation. Post-operative care in the recovery. What should you do in the recovery? Frequent monitoring of the vital signs, pulse, respiration, blood pressure, and saturation. We always do. Watch for vaginal bleeding. Palpate the state of the uterus. Should be contracted. Breathing. Deep breathing is encouraged at this stage. Patient is still recovering from the anesthesia, but here the patient can have deep breathing to maintain her oxygen levels. Output less than 30 ml should indicate an unrecognized blood loss, antidiuretic effect of the oxytocin that was given during the surgery, or an unrecognized urinary tract infection, injury. So that should be kept in mind. Recovery room analgesia. What should you give in the recovery room? Optimal post-operative analgesia significantly impacts patient's recovery and outcomes after cesarean delivery, and also has a positive impact on the patient's psyche that she had a painless recovery from the cesarean section. For a standard analgesic regime, you use a long-term neuroaxial opioids because this time if the neuroaxial anesthesia was given to this patient, some of the effect of the morphine will still be there. Adjuvant drugs may be used in the form of acetaminophen, non-steroidal anti-inflammatory drugs are recommended unless they are contraindicated for some reason. Intrathecal morphine during the anesthesia indication. Epidural morphine, if the patient had an epidural for the labor analgesia, or during the cesarean you have sometimes combined spinal epidural anesthesia, it may be used, and morphine 2 to 3 milligram may be given intermittently if the catheter is still a part of spinal epidural technique. Paracetamol and non-steroidal anti-inflammatory drugs can be still given around the delivery time and perioperatively. I consider a single injection of the steroids, a single injection of the analgesic like xalocaine or lignocaine around the incision site before you shift the patient from the recovery room to the wards. Post-op care analgesia, because post-op period is when the patient is brought to the labor from the recovery room to the wards. Adequate pain relief post-op is needed for the woman for the recovery from surgery, for early ambulation and resumption of activities, and to take care of a newborn. If an epidural anesthesia is given for labor or C-section, it can offer a good analgesia in the post-operative period. And a patient-controlled epidural is also coming into fashion, which is very effective. It gives a satisfactory post-operative analgesia and has been reported with dilute concentration of the ropivacaine 0.15 to 0.15%. Acetaminophen, tramadol, or diclofenac also can be given adequately to cover the post-operative period. Post-op period should have, we all know this, IV fluids, analgesia, monitoring, and antibiotics. And a clean, elective, and uncomplicated emergency cesarean section antibiotic prophylaxis with the 2 doses of antibiotic, one before the surgery, at least 30 to 60 minutes before the incision, and second after the 12 hours usually sufficient. Urinary catheter may be removed after 4 to 6 hours. Oral fluids can be started after 4 hours. Continuous pulse oximetry monitoring should be done. Hourly monitoring of respiratory rate, heart rate, pulse, blood pressure, temperature, pain control, and sedation. This is according to NICE 2021 guidelines. Post-operative fluids, how much fluid should you give and how long to give fluids? Aim of IV fluids in the post-operative period is to maintain hydration, nutrition, and electrolyte balance. Usually 2 to 3 liters of fluid were infused during the surgery in uncomplicated cases. If the patient did not have any excessive bleeding than expected, and 10 to 10 ml per kg per hour was given already during the infused during the surgery. Post-operative crystalloids are usually given in the combination of 5% dextrose and ringer lactate to maintain the electrolyte balance. Intravenous fluid optimization is needed. About 3 liters per day, about 6 to 8 hours of IV fluids is adequate for post-operative fluid intake. Till you advise oral fluid intake, you should be started after 4 hours. And RCT compared early versus late initiation of the oral intake after cesarean section to reduce gastrointestinal complication, and found that early intake after 4 hours and early feeding decrease post-cesarean gastrointestinal complication. So you can take the patient to the wards, and oral fluids can be advised after 4 hours of surgery, and about 6 to 8 hours of IV fluids should be sufficient. Antibiotics. Again, this has been covered to some extent by Dr. Sadhana. Prevention is better rather than treatment. Abdominal preparation with topical povidone iodine reduces the skin flora. This is a CDC recommendation. Preoperative vaginal cleansing with iodine decreases vaginal flora according to the ICOG recommendation. And a Cochrane review recently examined this topic and concluded that the vaginal preparation preoperatively, just a vaginal swab to cleanse the vagina before operating, probably reduces the risk of endometritis after cesarean section. It's a small intervention which will reduce the incidence of surgical site infections and endometritis. Antibiotic prophylaxis can help to reduce the risk of infection from cesarean by 60 to 70%. And the choice of antibiotic, of course, may depend on the clinical scenario, whether the patient has a clean elective section or an obstructed labor section. There is no benefit of broad spectrum antibiotic. A single dose of 1 gram of cephalosporin, usually first generation cephalosporin, is sufficient for an uncomplicated cesarean section. Azithromycin 5 milligram IV can be given. 900 milligrams clindamycin, aminoglycoside 5 milligram per kg body weight, 60 minutes before the incision should be given as an in any one of these. It should not be given combined. First generation cephalosporin ampicillin usually should be the first line of choice of antibiotics. Women sensitive to penicillin may be given gentamicin or clindamycin. Women in labor with ruptured membranes, it is useful to give azithromycin 500 milligrams intravenously. Antibiotic, a Cochrane review in 2014 found that pre-incision antibiotics prior to cesarean section reduce the incidence of infection compared to no prophylaxis. And again, this is prior to the skin incision or prior to the cord clamping. It is better to give the antibiotic before the incision. And the guidelines development group, WHO group, emphasized the importance of giving a single and a short single dose of 30 to 60 minutes before the surgery antibiotic regimen for the prophylaxis. Amoxiclav preparations can be given 1 gram before the surgery and to be avoided in the baby. If the baby is preterm, amoxiclav causes necrotizing enterocolitis in the baby, which is preterm. So it should be the rate of antibiotic should be given 30 minutes or 60 minutes. Infection rate are similar, so it does not matter. You should have an antibiotic in the blood circulation at least 30 to 60 minutes to prevent post-operative infections. And at the time you give incision that causes a transient bacteremia, at that point, if the antibiotic is already in the circulation, it helps to prevent the bacteremia and the infection thereupon. Foley's catheter, when to remove it? It may be removed 12 hours after the surgery or for the convenience next morning after the surgery. This is according to Williams 24th edition. But the prevalence of urinary tract retention after cesarean section is 7% due to surgical trauma during the section. A CDC recommends use of the smallest possible catheter for a short duration to avoid injury to the urethra and to prevent catheter-associated urinary tract infections. And ERS recommends, this is early recovery, recommends removal of the catheter immediately after the surgery. They said there is no need of a catheter once the surgery is done. You just need the catheter to deflate the bladder during the cesarean section is done. And the Cochrane review reports a decreased rate of UTI with the immediate removal of the catheter. But according to a lot of other SCOG and SOP criteria, this could be too early because the pain relief is given for the cesarean section with the opioids. Patient may not be good enough to rise and go to the toilet or have to avoid urine. The Society of Obstetric Anesthesia and Perinatology guidelines, that SOP guidelines, recommends 6 to 12 hours of postpartum protocols with managing postoperative catheters. And NICE guidelines recommends catheter removal, but no sooner than 12 hours after the top of dose. So there is a debate whether some guidelines say early removal, immediate removal, 6 hours removal or 12 hours removal. I would suggest a 6 to 12 hours removal of the catheter is good enough. So the earlier you remove the catheter, the better. The catheter-associated UTI also become less. Ambulation is key to prevent thromboembolism, and early ambulation enables mother to mobilize within 12 hours of surgery, helps to reduce the use of opioid for pain, increases mobility and breastfeeding and early oral intake. So quasi-experimental study on the effectiveness of the planned early ambulation and post-op recovery was done, and all patients and cesarean mothers concluded that the early ambulation improves the post-operative recovery and helps to achieve a good sense of well-being in women who had cesarean sections. So early ambulation is definitely, yes, it should be. Even immediately after the surgery, 4 or 6 hours, patient can be made ambulant. Wound care, how should you take care of the wound? A saline dressing should be done after the wound has been closed after the cesarean section versus the betadine dressing, because betadine can enter into the skin lines, can retard wound closure. So just plain saline dressing is better for the better approximation of the skin. Consider negative pressure therapy for cesarean for a woman for BMI of more than 35 to secure a reduce the risk of wound infection. This is NICE guidelines. Remove dressing after 24 to 48 hours. After the immediate skin approximation usually takes 24 to 48 hours. After that, there is no need of a dressing. So you can easily remove the dressing, keep it open and clean and dry. And there is no risk of wound infection when the dressing is removed after 6 hours post-operatively compared to the 24 hours post-operatively. This is according to NICE guidelines. So usually 24 to 40 hours, so you can remove the dressing, keep the wound clean and without a dressing, keep it dry. Subcutaneous absorbable subcutaneous stitches need 7 to 10 days to disappear. And that is the best kind of stitch line to have, because you don't need to remove the stitches. Patient does not need a post-operative visit to remove the stitches. If you have put non-absorbable stitches to be removed after 6 to 7 days. When to discharge this patient? Usually by 3rd or 4th day, patient can be discharged if the baby and mother are stable. Patient has opened her bowel and she is non-pyrexic. Many centers in Europe have a practice to discharge after 48 hours. An RCT in UK compared discharge after 48 hours to discharge after 24 hours and found satisfactory scores of pain scores at discharge day 1 and 6 discharge were not significantly different in the study groups, and they were very significant, no significant differences, and they even discharged their women after cesarean section after 24 hours if the baby and mother are fine, or at the most after 48 hours. I think it is little too early for our Indian scenario because women don't take care of their wounds after going home. So I would suggest 3rd day, 4th day discharge should be optimum for Indian scenario. After you find that the baby and the mother are stable and baby is not jaundice, mother is not pyrexic. Another key finding in this paper was there was no significant difference in surgical site infection, separation of the incision, endometritis, urinary tract infection or gastrointestinal complication or secondary PPH in the women following discharge when the women were discharged after 24 hours and 48 hours. So you can take a leap of faith and discharge women after 24 to 48 hours. That is a UK study, and I think it can be done if you are comfortable discharging patients after 24 hours. Advise I discharge. Of course, this is a standard protocol that we all follow: hygiene and nutrition, iron and calcium supplements, exclusive breastfeeding till 6 weeks, WHO guidelines, immunization. Contraception is a very important step that we forget to take sometimes, because this woman had a cesarean section. She should have adequate spacing for the next pregnancy and to have optimum care for the baby and recovery for the mother. Follow-up advice has to be given to the patient. Warning signs that to tell the patients about fever, dysuria, excess vaginal bleeding, foul vaginal discharge, and wound discharge. She should come to you running if one of these signs patient finds after discharge. So immediate post-operative guidelines, post-operative monitoring. This is a systematic postpartum management practice guidelines. So this can use a professional consensus for the different guidelines that I have already covered. So I don't have to repeat them. They all say the same things that we have covered during the previous discussion. To summarize all the discussion that we had for the post-operative care and complication, although cesarean section is common, it has its share of complications. Rising number of sections is adding to the number of complications, and that's a cause for concern for us. Care should start with the preconception counseling, where the patient's comorbidities could be treated, could be normalized, the optimization of the weight, control of the diabetes, correction of anemias, and take care of any antenatal pre-pregnancy comorbidities that the patient has. Antenatal care has to be vigilant to take care of the antenatal complications, and most important is the preoperative preparation. Diligent precautions during surgery, antibiotic prophylaxis, use of analgesia in the recovery room, and post-operative monitoring may avoid major complications. Precautions during closure, during closure of the wound after the cesarean section. Hemostasis is very important. Many of these women would be hypertensive, which show hypotension during cesarean section due to hypotension of the spinal anesthesia, and they might, during the recovery time, they may have a reactionary hypertension and cause bleeding. So that hemostasis has to be absolutely perfect. Close all the dead spaces that you have done. Anatomical approximation of the tissues, less tissue handling, avoid tissue desiccation and prolonged surgeries. And these are the good practices. This comes under the Halstead's best practice of surgical management. Early ambulation, early feeding, early discharge from hospital will take care of the post-operative complication, minimize the post-operative concerns for you as well as the mother. Follow-up, basically follow-up should we look out for the complications and counsel the patient for the consequences of the next pregnancy. And the most important, and not to forget, the idea is a contraception. And thank you so much for a patient listening. This is not in any way an exhaustive list of complications after care. I may have omitted some points, but every complication in this list is a webinar topic in its own, deserves a webinar topic. So I hope I have done justice to the topic. Thank you, Rekha ma'am, for sharing the session. And I hope I have covered all the necessary complications that were desired by the panel. Thank you, ma'am.
Thank you so much, ma'am. It was a great talk. Wonderful.
Thank you so much.
You
Thank
covered everything. So over to the chairpersons for their expert comments.
Is like Archana is there or not for her comments?
No, ma'am, she is unable to join. Probably she has some guests.
So the
Excellent.
topic
Dr.
which
Anjali, you stop the slide share just so that we can listen to chairperson comment.
Okay, ma'am. Yeah, I'll do that.
Dr. Anjali has just done the justification to the topic. Though she has summarized few things because there was overlapping of contents. So still she has covered almost all the care part and complications. But say from private practitioner point of view, we differ in few things in management. This is a standard thing which should be done. But what we do, we don't give antibiotic for 2 days dose only. Practically, we are giving antibiotic injectable for at least 24 hours, followed by oral antibiotic till say 1 week. Secondly, it is very difficult in private practice to remove catheter after 12 hours. If cesarean is done in the morning, we never remove catheter in the night because patient is reluctant to go to toilet. So we remove catheter after 24 hours. Then we change the dressing on 3rd day. And then we leave the patient, we discharge the patient on 4th day. We are not able to discharge patient on 2nd day or 3rd day. So these are the few practical things which we are not following according to protocol. We are differing slightly on the protocol, but otherwise this protocol is very, very important and it is self-sufficient. If everything is followed according to protocol, everything goes well. That's all.
Thank you, Rekha ma'am, for the expert comments. So now we come to the end of the wonderful workshop we had today. And I would like to thank everybody for joining and sparing their valuable time and staying with us till end.
And thanks, Dr. Amrita, for coordinating, for calling us time to time, reminding us. Thank you so much.
Thank you, ma'am.
Thank you. Thanks also.
It was greatly required in Uttarakhand to have this workshop. And this is very useful for everyone. And we have a wealth of knowledge. We have become...
Unmute yourself. Meenu,
it was very much required workshop in Uttarakhand. And it was Dr. Sadhana Gupta idea. And Amrita did a lot of work to bring all of us together here. Great job done by Dr. Amrita and very good workshop. We are now full of wealth of knowledge.
Yes,
cesarean section. We are doing cesarean section daily, but Dr. Sadhana Gupta talk, Dr. Anjali talk were very excellent, and Ruchira compiled the cases very nicely, and the panelists were very excellent. And Dr. Sadhana will comment something on the last talk, please.
Ruchira, you stop slide share so that it is like so that we get direction. Stop slide share this thing. Stop the slide share. He's there or not? So actually, why we are taking this talk all, which is actually not discussed, because when we go to the literature, so every tertiary care center is having so many cases of the referred cases, like the post-cesarean bleeding, like post-cesarean like urinary injuries, post-cesarean bowel complications. So it is not that rare. And what Dr. Anjali and we have said that the right protocol and the right timing antibiotic is the Meghna's comment was very valid, because it is not only in the India what we say, in all South Asia we say that, when we were in the England, we were using one single, but when we came to Bangladesh, we are giving 5 days antibiotic. So this is, I think, most of us, I think, including me, we are giving 5 days antibiotic. Though the experience like from Safdarjung, which is a very, very heavy loaded, Dr. Manjupuri, etc., always emphasize that we are giving only single shot and it is doable. Sometimes we don't have the courage to have that, because in a single patient goes into sepsis, it is the important thing is that everybody is in overhead in the private practice, and that's why we have to look at, just say, patient catheter. They don't want to sit down on the pod. They don't want to go to this thing, and sometimes it is due to the feasibility. Though we can have always the courage, and what I say that ERAS is something which we have to look, because cesarean post-operative care is different. It is the breastfeeding, it is neonatal care. Patients like sleep is disturbed because we are always pushing breastfeeding, and that emotional component, and then the other situation which is related to the cesarean, that is the postpartum hemorrhage of various etiology, drugs, and the why the indication. So just to keep this talk is that these are the cases where we actually get most of the legal issues after cesarean section. Most of the thing, because it was not caught. Bladder flap hematoma, so many times we have that blood collection and that goes on. Secondary postpartum hemorrhage after 5 or 7 days. So bringing up this, that every person must be have that respectful to the post-operative care and never shift the patient to the normal ward. It is the for 24 hours and at least for 10 hours if the workload is heavy, to keep into the ICU so that we have all the looks into the vital. So finally, cesarean is always a full respect for the full surgical procedure, right from indication to the post-operative care. And we must understand that cesarean section is something very different surgery. It is not for the disease, it's for physiological, involving two people, and most of the time whole of the family and mohallas are involved in that cesarean section. Kyun hua, kya hua, unke yahan aisa hua. So a lot of pressure on us, and it was wonderful learning, wonderful panel, beautiful talk. Meenu se to aaj maine ye baat ki 1, 2, 3, 4 kaise 2 or 4 ko that was something very like observation, and I think Meenu, we will carry this your point to all teaching. And
I think that
we are learning from each other. Everyone teaches us something.
Yeah, that
First
chart
time
should be
we
pasted.
हाँ
That chart should be pasted in the labor room.
हाँ, हम लोगों ने
we have
कभी
to
इसको
see it
ट्राई
to
नहीं
learn.
किया.
हाँ, कभी नहीं
First
सोचा.
time we are
Yes.
we will get it.
It is an excellent webinar.
Yes,
Excellent
wonderful.
cesarean section webinar, and
साधना मैम को सुनना तो
training
बहुत ही
from Uttarakhand people.
Yes,
And request to all the Uttarakhand people, please support Dr. Sadhana. She is the most capable and capable president to be. So
Yes,
please
ma'am.
support wholeheartedly to her. So
Yes.
we are with you, ma'am, always.
Yes, and all the best, ma'am. All the best.
Our society
All
is
the
with
best.
you.
All the best, ma'am.
All the best,
I
ma'am.
appeal
All the best.
everyone that not a single vote should go wasted because of not voting. Please vote everyone. Sangeeta, we have a very close relationship.
Yes, ma'am. Yes, ma'am.
So we look forward to a wonderful day and on yoga. Yes.
Conversing
Okay, ma'am.
candidate. I will converse for you.
Yes.
Okay,
Sangeeta
ma'am.
can do.
So in the end, I would like to propose the vote of thank. And at the outset, the first and the foremost, I would love to thank our chief guest, Dr. Jyoti Sharma, for her blessings and showing her confidence and belief in Sadhana, ma'am. My gratitude to our guest of honor, Dr. Anu Dheer, who took out time from her busy schedule and blessed the webinar and Sadhana, ma'am. Dr. Meenu Vash, I have no words for all the help in coordination. And the best thing was teaching us the trick to memorize and learn the Robson's criteria. So it was wonderful, ma'am.
Thank you,
Our
dear.
chairpersons, the most loving Dr. Sarveshwari Nautiyal, Dr. Jayashri Tiwari, Dr. Sangeeta Singhal, Dr. Reena Ahuja, Dr. Rekha Srivastav, and Dr. Archana Singh. You joined us and gave and shared your knowledge and experience with us. It was overwhelming. Dr. Ruchira came up with a wonderful panel besides her tight schedule and lot of commitments today. Our expert, Dr. Geeta and Dr. Aarti, they gave great inputs. And at the end of the panel, we had a final word in all the cases, no confusion. Our learned panelists, Dr. Tanuja, Dr. Archana Luthra, Dr. Jyotsna Agrawal, Dr. Anshu Kakkar, Dr. Anushri Rawal, Dr. Pawan Preet Gill, Dr. Savita, Dr. Anshu Kakkar, Dr. Archana Singh and Sangeeta Garg. All of you were wonderful and we learned a lot from you all. Madam Anjali Chaudhary gave us the evidence-based talk on complications, right from sepsis, thromboembolism, hemorrhage, wound infection, fetal complications, and subsequent pregnancy complications. Everything was covered. Sadhana ma'am for making me a part of this amazing series, and a great talk on techniques and highlighting the scar niche in her talk. It was great, ma'am, to listen to you. And I've learned I've heard you so many times, the same lecture, but every time I learn something different from this.
We all learned a lot from all of us. Thank you, ma'am. Thank you, Amrita, ma'am.
And yes, and
called
thanks
me.
to dear
Thank
Ritu,
you.
who was here with me, shared the platform with me, and all the attendees who joined us today. And your
Thank
thirst
you,
for
Corona also. Thank you, but thank to Amrita and Ritu that they are working so hard and thank you, Ruchir Gandhi and Corona.
Thank you,
We are always after you for this thing and that thing, and thank you for they always
Ruchir
being
must
with
be
us.
fed up of me. He must be fed up of me.
Oh
every
no,
time.
ma'am. No. This is my
Job.
this is
It
my
is your
privilege
job,
to
like
expand your reach and as well as to reach to this much of experts all over India. This is I think my third or fourth webinar with you. I would like to do this type of program more and reach more people.
Thank
Lovely,
you.
lovely.
Good
You
night.
have done the
Lovely.
job excellent.
Thank you,
Ma'am,
Meenu.
just
Thank you, Meenu.
just
Thank you.
Thank you,
just
ma'am.
a
All
2
the best
minutes.
to you.
Just 2 minutes, madam. We have introduced 2 products in our gynec portfolio recently. Just 2 minutes. It will not take.
Bataiye.
First is already everybody is using, that is duratocin RTS, that is carbetocin. This is a drug which is a patented drug. This was a patented drug introduced very long back, and we have a special patent, special association with Ferring Pharmaceutical. This is an innovator drug. This is a room temperature stable drug. So on 40 degrees, 30 degrees also, you can use this product without any worry. It has a rapid onset of contraction. It has a sustained action, as well as no infusion is needed. So the one advantage already said, for safe motherhood, we should have a prevent the PPH, and for that, madam, it delivers a reliable efficacy in a single shot. It has a proven half-life and enables sustained action, and it requires no refrigeration for maintaining the effectiveness, and it reduces the additional uterotonics in all forms of birth. Madam, duratocin is one step ahead of uterine autonomy, where oxytocin is required for vials and multiple dosing, and other uterotonics. Duratocin doesn't require that. In slow IV push, it can be given in 1 minute, and in IM, it can be given in 1 shot. Apart from this, madam, we have now introduced second product, that is for next. This is a revolutionary iron supplement, madam. This is a product which is non-salt oral iron. This is a complex iron which doesn't have GI irritation. Mainly, black stool is the one of the biggest problem which we find when giving iron. And the black stool and GI irritation will be very less with this. Long-term efficacy data is available for 64 weeks. It is uniquely formulated to provide optimum iron supplement. It reduces ROS and GI side effect, and it can be absorbed through mucosal enterocyte of GIT. And it has a moringa leaf extract which increase the iron level. This is a new formulation that contains ferric maltol. Ferric maltol is not available in oral form in any formulation in India right now. So this is the first formulation. I would urge that you use and you share your experience on this. Thank you very much, ma'am, and thank you from House of Corona for your excellent sessions.
Thank you so much.
Thank you.
All the best to you also. Thank you. So we can leave now.
Yeah, we can
leave. Thank you, Amrita. Thank you. Dr. Anjali,
Thank you so much, ma'am, and all the best. All the best.
Thank you. Thank you.
Definitely, but today I was really impressed with the way the webinar was conducted and the way everybody spoke. And ma'am, especially your contributions are most valuable. And I think I wish you all the best in your future endeavors.
Thank you.
Thank you,
madam.
Thank you, ma'am.
Thank you. So, Ruchi, you can close the meeting.
Yeah.